conference conducted by the departments of Pediatrics and Diabetology, Kauvery Hospital, Pediatric Diabetes Update 2020. I would like to share a small story connected to this CME program. About 3 years back, that is in 2017, we had 4 children admitted in our pediatric ICU with severe diabetic ketoacidosis. All these admissions happened in just single month. Among the 4 children, 3 were newly detected type 1 diabetes, and the 4th one was already a known diabetic for 2 years under insulin. Among the 4 children, 1 developed cerebral edema, and the other child had acute kidney injury due to severe dehydration. Anyhow, they all recovered and they got discharged. At that time, we had a discussion on how to prevent such admissions in future and what is our role in it as a tertiary care center. The unanimous answer we got at that time from everybody, both from diabetes and pediatric side, was we should educate them. Yes, we should educate diabetic patients, educate the families of diabetic patients, educate ourselves, and also educate the primary care physicians who are the first points of contact for these children. அப்போ தொடங்கினது தான் இந்த pediatric diabetes update. So far we have had 3 conferences, 3 consecutive years. The highlights of the CME program are workshops, seminars, debates, exhibitions, and interesting lectures on the management of pediatric diabetes care. At this juncture, my sincere thanks goes to Dr. Sengutuvan sir for giving me all the freedom and guidance to conduct these educational activities. Thank you, Sengutuvan sir. And today we have 4 eminent speakers. Of course, I should say that they are all stalwarts in pediatric diabetes care to deliver 4 interesting topics and share their knowledge with us. Welcome you all, sirs and madam. Let us begin with the first session on childhood obesity. Friends, please, if you have any questions, type them in the chat box. We will have discussion at the end of each session. Thank you all. Over to Dr. Meghanathan and Vignesh to start the session.
Good evening. Today, I'm pleased to welcome Dr. Akila Ayavu, a very special guest from Coimbatore. She is a well-known and cool and down-to-earth person. Dr. Akila Ayavu is a senior consultant pediatric endocrinologist and diabetologist at GKN Hospital, Coimbatore, and she is teaching DNB students since 2003. Her qualification, her did MBBS in Coimbatore Medical College to 85 to 91, and done his DCHS 91 to 93 at ICH Chennai, and got done DNB from 2001 to 2003 at GKN Coimbatore, and it's done her clinical fellow and PhD in 2010 to 2013 in Starship Children's Health, Auckland, New Zealand. And she has published almost more than 40 scientific papers, and she authored chapters in 4 textbooks. Under her guidance, theses of 4 DNB students from GKN Hospital, they presented national and international meetings. She was awarded the best PhD students in research and publication in Slingings Institute in 2013 in Auckland. She has been organizing chairperson and secretary in various meetings like Indian Society of Pediatric Adolescent Endocrinology and Asia Pacific Pediatric Endocrine Society and Growth Hormone Research Society and National Assembly of Pediatric Emergency Medicine. She has attended free diabetes camp for children and diabetes and every year at GKN Hospital. Mainly her motto to educate and encourage children, and she is organizing free camp for congenital adrenal hyperplasia. At present, she is a secretary and treasurer of Indian Society of Pediatric and Adolescent Endocrinology. Now, ma'am is going to give a talk on childhood obesity and prevention and treatment. Over to you, ma'am.
Good evening, everyone. Dr. Gauri, am I audible?
Yeah, ma'am.
Okay.
Very
Thank
audible.
you so much. I am very, very pleased to listen to that. It was like I thought you were talking about someone else, and I didn't think I deserved too many of those accolades. You could have just said I was a pediatric endocrinologist. Thank you so much. I'm very, very happy to meet all of you, Dr. Gauri, Dr. Shanmugaredu, Dr. Sengutuvan, and my friends, Dr. Vignesh and Meghanathan. It's a pleasure to be here. And I hope you take some messages from here. It may be useful, but it may not be. You may know most of it. It's just a vision or an attempt to see if we could just open up a few thought process in childhood obesity. The amount of childhood obesity over the last several years, I'm seeing a huge trend. There is also a secular change. Earlier, all of our well-to-do patients were being obese. And as we see now, they are becoming more aware, and we are seeing lesser and lesser obesity in them. And we are seeing more obesity in the lower socioeconomic status. So the trend is changing due to the changes in the society and the way we look at things and the marketing of food and the cost of high-calorie food. So the relevance is there are 2.8 million people die every year due to obesity-related complications. The 2020 WHO fact sheet says overweight adults more than 18 years is more than 1.9 billion. Obese adults amongst them are 650 million. 39% of adults aged more than 18 years are overweight, and 5 to 19-year-old children who are overweight or obese is around 340 million. The prevalence of obesity has increased by 47% from 1980 to 2013. So the common reasons why do they come to the hospital? Most important, nobody's bothered about obesity because you're not going to see your complications now, it is in your future. So for boys to come into the hospital is because the penile development is not good. That's the most important thing they worry about. Whether he lives long and a healthy life or not, they have to be sure about fertility. That is what they are concerned about. And girls come because they don't have regular periods. What did we see in our hospital? I'm just using some of my data. We've had several studies being conducted at GKNM over the last several years in our obese children. And when Vimal Raj did a study on that, he found that 63% of prepubertal obese South Indian children have developed insulin resistance already. So they are on the way to developing type 2 diabetes. We are also seeing a proportionate increase in insulin resistance with increasing BMI. And we saw a huge amount of correlation between the HOMA-IR and their lipid profile and BMI. We also had Manmada Rao, who's another postgraduate who's looking at the other complications in prepubertal obese children. We looked at prepubertal obese children because they're so young. Their puberty is not interfering with the evaluation and analysis of insulin resistance. So we chose prepubertal children to look at the magnitude of the obesity that we are going to face in future. We noted systemic hypertension in 13% of them. Non-alcoholic fatty liver disease is already seen in 14%. We have also seen Perthes, Blount's, obstructive sleep apnea, Pickwickian syndrome. I had a 2-year and 2-month-old with severe obstructive sleep apnea and almost went into cardiac arrest twice in the recent past, and we had to put him on BiPAP for some time till he achieved significant weight loss and was able to maintain his respiration well on his own. So there's a very profound statement by Paul Zimmett, who's an authority on evaluation of obesity. This is the first generation where children may die before their parents. That's such a heartbreaking statement. You can lose anything in life, but you would never like to lose a child in your life. Your child is your wealth and your happiness. And seeing your child die in front of you is something so horrible, and this is preventable, which is what families have to realize. This is the first generation where children may die before their parents, and it is preventable. What is the definition of obesity? As WHO says, it's actually just excessive fat that impairs health. You are saying 80% more than the BMI, more than 85% for that age and sex. Those are all numbers. If it impairs your health, it is not good. It is obesity. But by definition, more than 85%, more than or equal to 85% of BMI for age and sex is overweight, and more than or equal to 95% is obese. The new IAP charts devised by Vaman Kadalkar and his team is actually very, very useful, because if you look at the BMI charts, he's actually made 23 equivalent for adult BMI as overweight and 27 as obese, in consonance with higher risk for metabolic problems in Indian subpopulation compared to the rest of the world. So it is not 30 and 25, it's 27 equivalent and 23 equivalent, and these BMI charts are very, very useful in children. So body mass index is actually more useful in the population rather than for an individual, but we use it because it's much more easier, because it's a number rather than just evaluation of other parameters. And all of you know it's weight in kilograms by square of height in meters. So what are the etiology of primary obesity? So you have modifiable risk factors and you have unmodifiable risk factors. What you are born with, what you get from your parents, your grandparents, or your genetics, that is not modifiable. But the way you eat your food, the way you run your life actually is a modifiable risk factor, whereas what you get from your parents is unmodifiable. So genetics is unmodifiable. What you do to yourself is modifiable. So genetics, epigenetics, how is the child when the child is conceived in the womb? If the child has defective blood supply, if the mother has severe hyperemesis gravidarum, if the mother has hypertension, if the mother has gestational diabetes, it can change the way your genetics exhibit itself so that you are at a higher risk for later disease. So for an example, if you have a 1.5 kg child who's a term small for gestational age infant who's born, these children have a higher risk for metabolic disorders in later life. So if you have a child who comes into your clinic, the mother says the child is not very bad at eating, eats reasonably, but puts on weight fast. That is a higher tendency. The child starved when the child was in the womb. So the body thought it is going to face famine or no food in later life. So acquires an ability to store fat very easily. So even little quantities of food can be converted into fat and they can develop insulin resistance, diabetes, stroke, cancer. Everything is higher in these children who are born small for gestational age. But remember, it's not universal across. A significant proportion of SGA babies face these morbidities in later life, but that can be modified by a good diet, a good exercise pattern, a good sleep pattern, and a good lifestyle in later life. And you need not go into those complications if you look after yourself well. So the environment can be changed, though you have genetics and epigenetics, which has worked against you. So we had a huge number of publications from New Zealand because my team worked on early life events and its later effects on obesity and metabolism. So I worked on 3 groups: post terms, children born to mothers with severe hyperemesis gravidarum, and the firstborn in each family. All of these are at higher risk for later onset of metabolic disorders. IVF babies, actually what we found was, it was one of my teammates who worked on that. They have a better metabolism than those who are conceived naturally. That was quite surprising for us. The parental influence on later disease include maternal obesity, gestational diabetes, paternal and maternal age, and hyperemesis gravidarum. So there was some interesting papers which I thought was very, very useful. Decreased duration of sleep, later bedtime sleep. I'm not sure how many of the participants are converse in Tamil. Manusha வந்து பொழுது சாஞ்சு பொழுது விடிஞ்சா பொழுது சாஞ்சா தூங்கணும் பொழுது விடிஞ்சா எந்திரிக்கணும். That's a very, very profound statement. Man and his metabolism is conditioned and the hypothalamus is trained to the circadian rhythm. So the alteration of sleep pattern is an important influence on later development of obesity. Increased electronics, increased amount of fast foods or fried foods, the proportion of carbohydrate, fat, and protein, reduction in their participation of household activities. When we were young, your mother would just say, just sweep the house, clean the toilet, wash the clothes. But now no child would listen. They would spit on a face and walk away because we have pampered them so much. Reduce physical activities. You don't have grounds. All the grounds are converted into buildings. You don't have place for the children to run. There are so many vehicles. It's unsafe for the children. So all of these contribute to the increase in prevalence of obesity in this community. And the other is the myth. This was a very interesting article from Endocrine Reviews. Chubby is healthy in India. Baby fat will go away. Studying well and getting first rank in school is important. You don't have to bother about your exercise and sports. Playing outdoors is unsafe, and eating ghee and butter are good for the bones. So we also looked at some of our outpatients. We just gave a questionnaire to see what did they see. Actually, these children were normal for their age. The weight was normal for their age in 78%, but the parents were totally unsatisfied with the way the children were eating. Children more than 3 years continued to be fed by parents. You don't have to feed your child, let them alone. If they don't want food, leave them alone. They have to choose when they want. They need to understand what is satiety and what is hunger. You have to learn hunger and satiety, and that is when they will program themselves so that they have a healthy lifestyle. And about in children under the age of 2 years, we saw more than 3 packs of chips per week in a significant proportion. More than 3 packs of biscuits a week. But more than 3 portions of fruits and vegetables was a smaller proportion because the lifestyle is totally different. So what are the clinical features we see? You can see acanthosis nigricans. They go to the dermatologists to have a fair skin. They keep on worrying about the dark skin and they think it's a dermatology condition and don't relate it to metabolic problems. Hirsutism, stretch marks, hypertension, accelerated growth. The amount of insulin produced because of insulin resistance can activate the insulin IGF-1 pathway, and you can be taller than your peers in spite of being the same age, and their parents are very happy because they think the child is tall. So it is only because they don't worry about the weight, they're only worried about sexual development and other complications. Increased waist-hip ratio. So that is one important and an extremely important point. A waist-hip ratio of more than 1 signifies a poor metabolism. Even if you're not overweight, if you're not obese, if your waist-hip ratio is bad, you have to keep a watch on this child and see that they alter their lifestyle. Features of secondary obesity, hepatomegaly, menstrual disturbances. So this is a central adiposity, a typical waist-hip ratio of more than 1. Look at the amount of central adiposity. The peripheral, you have to remember your central adiposity programs your metabolism more than your peripheral obesity. This is your acanthosis nigricans, and I think all of you would have seen this frequently. This is because of hyperinsulinemia, which is trying to maintain blood sugar in spite of insulin resistance. So you secrete more and more insulin. So you try to drop your blood sugars and keep it under control. So because of insulin, you get hyperpigmentation and acanthosis. But what does it signify? It means that you're working really hard. So what happens when you produce more insulin, it will push the blood sugars down soon and you will be hungry again. So they have an uncontrolled appetite which starts off, and that can be actually related to the acanthosis nigricans. So this is early onset obesity. This boy is just 4 years of age and he's already got acanthosis. And everybody thinks a young child is obese will not have metabolic complications later. I talked about one obstructive sleep apnea syndrome in a 2-year and 2-month-old child. We have faced, you should remember, the deposition of cholesterol in the coronaries can start as early as 2 years of age. So there is nothing like early obesity is okay. It is nothing to bother about. Please remember, I'm seeing Blount's disease in children under the age of 2. We're seeing slipped capital. Even today I saw a slipped capital femoral epiphysis. We see Perthes. It's really difficult to see all these children, and it is heartbreaking. Stretch marks, even on the armpits, in the elbow region. So this child was just brought because the penis was not developing well, but all that he had was a buried penis. There was so much of fat that the penis was embedded in the pubic pad of fat. This is not something to worry about. You first have to look after your metabolism so that you live well enough to have children and look after their lives. This is acne and hirsutism, which is because of polycystic ovarian disease. Again, look at her acanthosis, the amount of hirsutism and acne. These are all because of obesity, the amount of acanthosis again. So this is one of our boys who came to us at 6 years of age with a weight of 48 kgs. We looked at his metabolism and just advised diet and exercise. They disappeared from the scene for the next 2 years and came back at 8 years of age with a weight of 78 kilograms. And they hated me because I was a carrier of bad news. I tried to counsel on diet and exercise. So he disappeared from my vision again and came back at 10 years of age with a weight of 150 kilograms and was fainting. He had developed Pickwickian syndrome. His blood pressure was 200 by 140. He had right heart failure. He had left heart failure. His liver had gone for a toss. All his liver enzymes were off the scale. He also had severe obstructive, and as soon as he lies down, he could have a cardiac arrest. We could not do anything. When we had this boy, the bariatric surgery had not been approved in such a young child yet. And again, we could not have risked bariatric surgery in this child because he could not have lied down on the table in the theater. He would have arrested immediately. So we put him on a BiPAP, sent him home, and we could not try anyway, no medication is going to work. We sent him home and told them to continue BiPAP and see how long he's going to be alive. They stopped him from school and got him to walk from morning till night for 3 weeks, and he lost 30 kgs. They could have done it earlier when he came at 6 years of age and 8 years of age. The ICU bed broke apart because it could not bear the weight because the PICU is not designed to hold such a big boy. We also see a huge number of secondary obesity due to Cushing's, hypothyroidism, growth hormone deficiency. They have a mild central adiposity, but they're not really huge. hypothalamic obesity is really difficult. It's so difficult for those children. They just can't control their appetite. They starve for food. I had one boy who was 16 years of age, was put on such a strict diet and exercise. He went to a nearby blood donation camp and told he's 18 years of age so that he can get a free meal. He donated blood just to get that free meal because his family was so strict about diet. That much of drive will come from the hypothalamus to eat so much food, they just can't control their appetite. Abroad, I have seen a father give up his job and take his son and work in the sugarcane fields and lock the kitchen and the food cupboard to see he lost weight, and he lost 35 kilograms in 1 year. That was a boy with Prader-Willi syndrome. We see regularly Prader-Willi, Bardet-Biedl, and then Alström's. I've got quite a few Alström's, and then Down syndrome children are prone for obesity again. So this is one of my boys with hypothyroidism. And then he also had Van Wijk-Grumbach syndrome. Because of his obesity, he was obese only because of his hypothyroidism. He did not have pubic hair, but he had huge volume testis because his TSH was stimulating the testis. Because it shares a number of amino acids with the follicular stimulating hormone. This is one of my boys who had sudden onset of rheumatic heart disease. He had both the valves going for a toss, and such a sad situation. So sick so soon. He had huge doses of steroids and he developed Cushing's. But you cannot put him on exercise. He was on such strict control because he had severe rheumatic heart disease at the onset itself. He put himself on a strict diet, and I'll show this picture later and how well he did only with diet and exercise. I mean, on what possible exercise he could do while he was sitting without straining his heart. These are very, very typical patients of mine. These hands, the acromicria, thin tapering fingers, which you see here, compared to the dad's hands. This nail picking is very, very typical. And then this obesity, these are all patients with Prader-Willi syndrome. This is a family with two children. Look at the polydactyly here. He's already looking, actually, I had to mask his face because of identity issues. He has already started looking at things downwards because he's already developed retinitis pigmentosa. He's on visual rehabilitation to manage his visual loss in later life. And both the children have Bardet-Biedl syndrome. The family is unable to control the diet. They are not able to say no when the children ask for food. This is post-axial polydactyly in both the children. This is one of my very rare children. He's only 3.5 years of age and he weighs 65 kilograms with hypothalamic obesity, and he had PCSK1 mutation. So what are the implications for being obese in childhood? When you have hypertension in childhood, it tracks into adulthood. Increased weight gain and BMI before the age of 5 years will increase your risk for obesity in later life. The severity of metabolic syndrome in childhood will increase the incidence of adult type 2 diabetes, and the degree of increase predicts future disease. Metabolic syndrome in children and adolescents is defined a bit differently from adults. Abdominal adiposity, diagnosed type 2 diabetes or raised fasting plasma glucose of more than 100 milligram per DL, raised triglycerides of more than 50, reduced HDL of less than 40. That is something a bit difficult for Indians because quite a few of our children have lower HDL compared to the Caucasian population. Raised blood pressure, systolic more than 130 or diastolic more than 85. What are the investigations we do? We do a bone age to see how much of acceleration in bone age has happened to these children. We do a oral glucose tolerance test to detect both insulin resistance and also look at the fasting insulin. We'll do a lipid profile, liver functions and hepatic ultrasound if they're morbidly obese, thyroid function test just so that we don't miss a hypothyroidism, baseline cortisol when we think of a possibility, and then if need be, we do a VD cortisol and then also try to do a dexamethasone suppression test if there are any abnormalities. So what are the management? It's only diet and exercise. There's nothing else. Any other drug is questionable. If you have established type 2 diabetes, you can add metformin. For severe insulin resistance or pre-diabetes, I add metformin even in young children. But otherwise, there are no medications. It's diet and exercise, and only lifestyle modification. Earlier, the better. School-based and community-based programs and education of families and having meals together so that you look at your food and eat, chew the food, They all alter the type of adipokines and their activity on various parts of your body, including your hypothalamus. So this is my boy who had rheumatic heart disease, who had huge amount of steroids. Look at him at he is only on diet control and a bit of exercise. If my time is over, just tell me, Dr. Kauvery, and I'll shut down. Anti-obesity drugs, we don't use it at all in children. This is another of my boy who developed gynecomastia because of obesity, but then he has a tendency for keloid. So I did not advise surgery at all. He told me I will try my exercise, and look at how trim he's become. He got a little bit of breast, and he said he will just build it up into a six-pack and try to hide it himself. So pharmacotherapy is available, useful only if you have insulin resistance, hirsutism, dyslipidemia, or any complication. Even lipidemia, for 6 months, we use only diet exercise. Only after 6 months, and if it fails, and if it is persistent and severe, then we use drugs. So this is another of my patient with PCOS, diet and exercise, 8 kg weight loss. Then we added drugs. Look at her acne and her hirsutism. These all dropped off. We didn't take it off. So I think if my time is over, Dr. Kauvery, I will stop.
2 more minutes, ma'am. 2 more minutes.
Okay. Consequences of childhood obesity, as I already mentioned: metabolic syndrome, type 2 diabetes, adult obesity, non-alcoholic fatty liver disease, hypertension, dyslipidemia, obstructive sleep apnea, PCOS, eating disorders, orthopedic disorders, asthma, and other respiratory disease. The exercise, 30 minutes of moderate intensity aerobic endurance activity for a minimum of 5 times a week. And it can be cumulative of 10 minutes or more, adding up to a total of 30 minutes, or a vigorous intensity aerobic exercise for 20 minutes for at least 3 times of the week. But I ask my children to just run all through the day and not sleep during the day. Have a good sleep, look at your food and eat. We do a reverse lunch. Ask them to take their yogurt first, or the buttermilk, then their rasam, then their vegetables, and last would be the rice. Endurance exercise to improve muscle strength for 2 days of the week. Last option, yes, in the I think within a month, bariatric surgery is approved even for younger children. When you weigh pros and cons of whether this child is going to be alive or dead with complications, you have to choose. But remember, you have to be very, very strict with the choosing children for bariatric surgery. You have to talk about the irreversibility of bariatric surgery and what procedure are you going to use. I prefer preserving the pylorus in children. I don't want them to go with absence of pylorus through their life with a lot of complications. And then we also you have to look after their nutrition, and medical follow-up is extremely important. There's no point in doing bariatric surgery and letting them off into the society and just allowing them to go like that. They have to be on regular follow-up. Have your criteria very strict. More than 40 equivalent BMI without complications, more than 30 equivalent complications. If you have more than 2 associated complications like hypertension, diabetes, obesity, induced obstructive sleep apnea syndrome, be very, very strict before you choose anybody for bariatric surgery, and advise them and try lifestyle modification for at least a year before you advise bariatric surgery. Thank you so much. And this is one of my other lifestyle.
It was a very, very nice presentation, ma'am. Such a vast area of childhood obesity completed in 20 minutes. Thank you, ma'am. And we have 3 questions. One is on does breastfeeding reduce childhood obesity? Breastfeeding.
Yes, definitely. There is no controversy about that. Breastfeeding, exclusive breastfeeding up to 6 months of age, definitely reduces the incidence of obesity. It is definitely proven in several studies.
And there's another question. What are the non-medical and medical treatment of hypertriglyceridemia in early childhood and hypercholesterolemia in childhood?
I think
there are many children who come with high triglycerides, more than 300.
I think somebody looked at my patient day before yesterday. I had a huge, difficult patient 3 days ago with a triglyceride, 6.5-year-old child with a triglycerides 27,000 plus and type 1 diabetes. So I actually have published on familial hypertriglyceridemia. Insulin is an extremely useful option in these children. For this child, actually, I had to, she underwent a plasmapheresis and she settled down with plasmapheresis and insulin. So in familial hypertriglyceridemia, the treatment is different. When it is associated with diabetes, because diabetes or insulin deficiency interferes with the function of lipoprotein lipase, if you give enough insulin, the triglycerides will come down. So controlling diabetes is extremely important. But in primary hypertriglyceridemia without diabetes in children with obesity, it is because of insulin resistance. Just modification of your diet and exercise, and if it does not subside, you might have to use. And if it is persistent for long periods of time, otherwise I don't think you have to use insulin in children who are not a diabetic when they have hypertriglyceridemia. You could probably try fenofibrate 10 mg per kg per dose. OD we try, but I won't use it at all. Not in obesity with hypertriglyceridemia. I would rather go for diet and exercise. I use coconut oil, millets, because MCT oil reduces the amount of triglycerides. I use Sagar skimmed milk powder, which has only 1 gram of fat per 100 grams of milk powder. Hatson skimmed milk powder also has only 1 gram of fat per 100 ml of milk powder.
Thank you, ma'am. Thank you, ma'am. And MSc sir, Harish Kumar sir, do you have any extra points to add on this childhood obesity?
No, I'm fine. Thank you.
Thank you, sir. Thank you, sir. So we'll move on to the next session. Thank you, Akila ma'am, for joining us from Coimbatore. Thank you once again.
And Dr. Gauri, 1 minute. Dr. Gauri, that is with reference to the cereals. What advice, Dr. Ayavu, you normally give it to your patients? Pediatric cereals.
I didn't get your question.
Cereals.
Cereals.
Yes.
Which cereals? About millets?
No, forget about millets. Forget about millets. Because regarding, do you like to promote the brown rice, number 1, and pounded rice, number 2, and incorporation of millets and pulses along with cereals?
Yes, sir. I actually definitely advise them.
Would you like to
recommend
low-calorie ketogenic diets like that?
No, I wouldn't, sir. A sensible, normal pattern of diet is important. A significant, normal proportion of carbohydrate, protein, and fat. But definitely, yes, high fiber, unpolished rice and brown rice are definitely we use because the glycemic index is low. They go high slowly and they don't drop immediately. So they don't feel hungry immediately after that. So mixed with a lot of vegetables. So usually the lunch I say is kaikutal arisi with podalanga, pikanga, soraka mari kootu vechu saadathai pesanju kuda keera tottukittu oru tumbler more, oru tumbler rasam.
Yes, of course. Mere dietary modification can help to bring down the triglyceride levels to some extent, to a greater extent, along with the improvement of physical activity. No doubt at all. Yes. Thank you.
So we should treat not only the child with diabetes, maybe we should treat the whole family, the whole society, everybody to reduce childhood obesity, is it not? Everyone should be
improving. I'm seeing a lot of improvement in the way families are accepting, the way families are happy to accept suggestions now compared to about 2 or 3 years ago. Definitely there's a change. A lot of people are aware now. They are happier to accept change.
Thank you, ma'am. Thank you so much. We'll move on to the next session. I request Meghnathan and Vignesh to take over the line for speaker introduction.
Good evening to all. We welcome Dr. Harish Kumar, Professor and HOD, Department of Endocrinology and Pediatry, AIIMS Kochi, for the next speaker. He was the first in India to start the concept of combined Department of Endocrinology and Pediatry. The department started the first regular program for simultaneous pancreas and kidney transplantation in India. He has published more than 250 journals in national and international papers. He is the chief editor of Amrita Journal of Medicine, and he has trained more than 40 students in DM endocrinology and PhD. Apart from this medical field, he is interested in Vedic astrology and fisheries. Over to you, sir. Sir is going to talk about common errors in insulin therapy and role of teleconsultation in type 1 diabetes. Over to you, sir.
Thank you for the introduction. Can I have my slides on, please?
Yes, sir, it's preparing.
Is the slide on?
Just a minute, sir.
Just a minute, sir. It's sharing.
Oh. While we're waiting for the slide to come on, I'd just like to say at the outset that for the next 20 minutes, I just want you to sit back and relax, because I'm not going to talk any high science. I'm just going to tell you a few interesting stories. I hope you'll find them interesting. Can we go to the first slide, please? I'm going to start out by telling you about some common errors that we see in the use of insulin injections. Next slide, please. The first story that I'd like to tell you about is, my slides are not very important. They're just bullet points to remind me about what I have to say. The first story that I'd like to narrate is about a type 1 diabetic boy. He was 14 years old, and I think Dr. Kauvery mentioned in her introduction that she recently had a number of cases of diabetic ketoacidosis in newly diagnosed type 1 diabetes. And this boy presented the same way. He was a newly diagnosed type 1 diabetic. He was a 14-year-old boy. He fell unconscious at school while he was playing cricket, was the history that I received. And then he was admitted to the ICU because his parameters were pretty bad and he was very sick. So when I went and spoke to him in the ICU, he was very distraught and upset. Although he was by then better, I actually saw him on the second day after his admission. And when I spoke to him, he told me that he was in a complete state of shock, because the last thing that he can remember was playing cricket in his school. And then he fell unconscious. And then when he became conscious in between briefly, he found that he was in an ambulance. This caused a lot of panic. And then he became unconscious again. When he regained consciousness, he found that he was in an intensive care unit in a hospital surrounded by strangers. So it was an extremely traumatic event for this boy. And as I mentioned, he and his parents and caregivers were all in a state of complete shock, because although they had realized for some time that he was unwell, they never imagined that it was type 1 diabetes. In fact, they hadn't heard of a condition called type 1 diabetes. And when they were told that insulin would have to be started and continued lifelong, their minds were just frozen. So at this point, our professionals all started approaching him. I think even before he left the ICU, because a dietitian goes to see him to ask him what he wants to eat each day and so on. Once he started oral feeds regularly, she went and had a discussion with him, and she quickly finished her job. She told him all about the type 1 diabetic diet, calorie restrictions, what you must eat, what you must not eat. And what registered in his mind was what he must not eat. He must not eat chocolates, he must not eat this, that, the other, and so many other things. And so his mind just closed down to what she said further. The moment the boy reached the private room after he was discharged from the ICU, our counselor went in to see him and then had a long chat with him about how to cope with type 1 diabetes. The very same day in the evening, our diabetes educator went in and taught this 14-year-old boy how to take insulin injections. She told him that you have to take the injections yourself. And she also taught the parents how to take insulin injection. She taught them all about hypoglycemia, hyperglycemia, and so on. Gave them a number of leaflets, booklets. Gave the boy a free pen device, and then got him started on insulin, and she left. When I went for rounds the next day, both the boy and the parents were in a state of complete shock. And I mentioned in detail about our various professionals, because if you look at it, all the professionals had done their job. But the job was actually a total failure. This is absolutely not the way to educate somebody who has type 1 diabetes, or even somebody who's starting in insulin and has type 2 diabetes. So what resulted was that the boy went home, and 2 days later, his parents came and met me and said that he's totally dejected, and he has rejected all the advice that has been given in the hospital. In fact, all the booklets, the pen device, the insulin, everything was found thrown in the bin outside their house, which means that none of it has sunk in, and he has rejected the whole thing. He can't cope with it. The message I'd like to leave you with this case is basically that we must target our education to the situation and to the patient. When the patient and caregivers are in a state of shock, if we are going to try and push a lot of education, it's not going to go through. Education is not our professionals. I think as professionals, we tend to go through a checklist all the time. Maybe we do this even in our OPD when we are seeing a patient. How's the HbA1c? How's the blood sugar? How many hypos? And then we are very mechanical about the whole thing. So you miss the forest looking for trees. Education has to be given both to the patient and the caregiver at a time when they are receptive. You just have to give them that time. With type 1 diabetics who are newly diagnosed, I personally found that mothers are extremely emotional. They're really upset. Fathers probably have a more intellectual approach towards life and are less emotional, and they are probably more accepting and probably ready to learn how to give, take and give insulin injections and so on. But nevertheless, it's a very tense situation for the whole family. So I think education has to be given very carefully. You may have to call them back once they've settled down, and then maybe you can teach the mother or father initially, and then just because the boy is 14, you cannot assume that he's going to overnight learn how to take insulin injections or indeed accept taking insulin injections, although he doesn't have a choice. Also, a regime has to, can we go back to the previous slide? The regime has to be suitably individualized, because all the patients cannot take the same regimen. Generally, ideally, for a type 2 diabetic patient, you need an insulin pump. In the West, all the patients are given insulin pump for type 1 diabetes. And I think there's a talk on insulin pump, so I won't delve into that further. Analogs are also good for children because analogs work very quickly. If you give children with type 1 diabetes human insulin, you find that you have to take human insulin ideally half an hour before the meal. And that's frequently not possible. If you look at the lifestyle of a child, he has got to go to school. So he probably take the insulin just before he sits for breakfast or just after the breakfast, if he remembers, and then run out going to school. So if it is an analog, it works much more quickly, and hence compliance will be better. They'll adhere much better to the time, and that way it will certainly help. Sometimes basal bolus may not be feasible because children cannot go to school and take insulin. Insulin is given over the arms and on the thighs and the abdomen, all of which are covered with clothes. So normally you have to have a moment of privacy to take an insulin injection, which may not be always possible when the child is in school. So you may have to adjust for a twice daily insulin, or maybe if the child comes home in the evening, so most of the schools nowadays finish by about 3 p.m. in the afternoon. And then the child comes home and has a fairly heavy IT or maybe even a meal. So you can give a fast acting at that time and do pre-mixed insulins before breakfast and before dinner, because at breakfast and dinner is usually at home. So you have the time and the privacy to actually take the insulin injections. So you need to consider all this when you actually think of a suitable insulin regimen for a type 1 diabetic patients. Next slide, please. Now, I'll just emphasize some of the errors which, as physicians, we often probably don't pay much attention to and tend to miss. This is a well-controlled child who had type 1 diabetes, and then suddenly when the child came to see me, there was a lot of fluctuation in the blood sugar values, occasional high sugars, and unusually quite a few hypos as well. And so clearly there was a lot of panic in the family, and they didn't know what was going on. The problem was actually fairly simple. The child was injecting over the same site repeatedly, and as a result of which he had developed some large insulin injection site lumps. So you sometimes get hypertrophy over the site of the injection. Whenever you see a type 1 diabetic patient who's taking insulin regularly, maybe multiple times a day, you must run your palms down the injection sites. Just palpate the thighs where the injection is, the abdomen, and the arms. Because if you can just run your hand down, you can feel there may be injection site lumps. If there are injection site lumps, what happens is that when the child injects into the lump, the absorption of insulin is very low. But when this child injects just at the edge of or outside the lump, then the absorption is very good. So because the sugars are generally high, they tend to increase the insulin doses. And then when the injection is given just outside the lump area, you may have a hypoglycemia. So this results in very erratic blood sugar control. This is something which you as a physician can pick up. We must tell our patients to rotate insulin injection sites regularly. We do tell them, but then sometimes they don't understand the importance. And when you're taking insulin multiple doses over a long period of time, you tend to become very casual and then just inject where it's convenient and forget about it. So this is something that you always need to watch out for. If there is wildly fluctuating blood sugar for no apparent obvious reason, then the first thing that you should look at, the simplest thing is look for insulin injection site lumps. And if they are there, then advise the child to rotate to other sites. If you leave the site of the lump alone for 4 to 6 weeks, the lumps will disappear, and then you can reuse those sites. Next slide, please. This mismatch of syringe and insulin is an extremely dangerous situation, which happens quite regularly and frequently in our practice, because I think India is one of the few countries in the world where you still get 40 IU insulin and 100 IU insulin. You have 40 IU syringes, you have 100 IU syringes, and always mix and match can happen where somebody takes a 40 IU insulin and a 100 IU syringe or vice versa. So I'll just narrate my experience. I had a very nasty experience with this 12-year-old type 1 girl. Actually, I think in the introduction it was mentioned that one of my hobbies is to study Vedic astrology. And a few years back, one night I was sitting, I usually get time only at night to read and study astrology. So one night at about 10 o'clock, I was sitting and by hearting some Sanskrit slokas in astrology, when I suddenly got a call. Those days I was not using a mobile phone, so the call came on the landline, and it was from the police station. And they called me to say that I should come to the police station right away because there was a case that I had conducted some kind of gross, what was the word used? Grievous injury I had caused to somebody, and so I should come into the police station right away. So I told them it was 10 o'clock at night and it was a little difficult. Maybe I could come tomorrow morning. So they allowed me to do that. When I went to the police station the next day, that was the first time I had gone to a police station. I didn't know I was supposed to take a lawyer along with me and all the rest of it. I found that there was an FIR by the girl's father. Now, what had transpired was that this girl was a regular patient of mine. And since the last 2 weeks, they have been calling me intermittently because she suddenly started having severe hypos during the daytime and during the night. And at night, she started having seizures. The hypoglycemia was very severe. So one night they took her to the local hospital and then they called me and I said, you cut the night dose of insulin down. Then again, she had seizures the following night, and the parents were so anxious that both mother and father were not able to sleep at night because they were so scared whether this child would have seizures. They were afraid to take insulin. They were in total panic. So each time they would call, we would discuss various things. After the third call, I asked them to just check whether the syringe and insulin were matching. And they said that no, it was actually a 100 IU syringe. They read out the label and it was human insulin 100 IU which had been given to them, whereas a syringe which they used was a regular 40 IU syringe. And they were until then using a 40 IU insulin as well. So then I realized what the problem is. The child was getting 2.5 times the prescribed dose. That's why she was going into severe hypo. So they wanted to know who had actually prescribed this insulin, and they thought the insulin had been prescribed by Amrita Pharmacy because they usually buy the insulin from there. So obviously it was some kind of mistake on the part of the pharmacy. So this gentleman, the girl's father, was a sub-inspector of police. So he went into the police station and gave a case saying that grievous injury had been caused to his daughter because of medical negligence. And his primary complaint was against the pharmacist, but he didn't know who the pharmacist was. So the only name in the complaint was mine, which is why I was summoned to the police station. So the other small but vital lesson I learned with this was before this matter went to court and I spoke to the lawyer asked me, have you documented all your telephone conversations in the patient notes? And I said, no, I usually don't document telephone conversations. So he told me, you must, because if this matter goes to court, then anything which is not in the notes is not accepted as evidence. So if you say you spoke like this and you found this out, you're on your own. So we always need to watch out for this. Next slide, please. This is the reverse. This was a very smart patient in the Gulf. We have a lot of patients from here who travel to the Gulf. And his son, who was a type 1 diabetic, ran out of pen fills. So one of his close friends was using vials. So his friend told him that this is the same thing. It's the same insulin. It's from the same company. So why don't you put this into the pen? So what the father did was that he borrowed a 40 IU vial from his friend and then injected it into the empty pen fill. He filled the pen fill with it. And then they quite happily began to use the pen again, thinking that the insulin was there. But this was a 40 IU insulin from the vial. And so he was getting only 40% of the prescribed dose. So obviously his sugars were very high. So unless you actually take a detailed history and you're alert to these situations. If you don't ask the right questions, you won't actually be able to find out what the problem is. If you're in a hurry and you're running a busy clinic, somebody's sugar is not high, you just increase the insulin dose, or you think they're not watching their diet and so on. I think all these aspects of insulin errors must be kept in mind. Subsequently, I had another patient recently, a type 2 diabetic patient, who did the same thing for economic reasons, because she found out that the 40 IU vial is much cheaper than the pen fill. And she also thought it's the same insulin. A layperson doesn't know better. So she also extracted the insulin from the vial and then filled her pen fill with it and continued using the pen. So such incidents are not uncommon. Next slide. Storage issues. I think our patients have a number of queries and doubts about storage, which leads to a lot of confusion. One of my patients got a large contingent of insulin from his son, who brought a lot of insulin from abroad. And then he thought that maybe it will get spoiled if we keep it in the fridge. That's what we do with food, isn't it? If you're keeping it for a short time, you keep it in the fridge. If you keep it for a long time, you keep it in the freezer. So he dumped all the insulin in the freezer and then came and asked me whether it's safe to use. The short answer is insulin should not be stored in the freezer. Once it's stored in the freezer, it will denature and cannot be used. I think people also have a lot of doubts about using insulin and how to store insulin while traveling. There are clear guidelines about this. We must teach, especially our type 1 patients who need to carry insulin when they're traveling, about how to store insulin safely when they're traveling. The other practical problem which I come up with frequently is how to store insulin without a fridge. I had a type 1 boy who didn't have a fridge in his house. He was from a poor family. So we found out that there was a fridge 2 houses away from his house. And then he said that he would store the insulin there and then go and take the insulin twice a day from there. Initially, the family who had the fridge were very welcoming. They felt very sorry for him and they said, oh, poor fellow, let him store the fridge here, the insulin here. He can come in any number of times. But the boy soon found that when he went every morning and evening and rang the bell, after some time, they got a bit irritated and they were not very happy to open the door and give him the insulin. So he told me that he was feeling very shy to go and trouble them each time. The situation for such patients is to keep the vial which they are currently using. It can be kept in a cool, dry place quite safely. We usually advise them. I think most houses in Tamil Nadu and Kerala have what we call a puja, which is a large earthen pot where water is stored. It's a round bottom vessel. Pot. So usually some sand is kept around it to prevent it from rolling. So if you store the insulin in vial in that, you'll find that it remains quite cool and can be used without getting denatured. Next slide, please. I think another point I'd like to highlight is that you need to roll a pre-mixed pen and make sure that the insulin is properly mixed before you actually take the injection. Many people, when they are in a hurry with a premixed insulin, if the cartridge is new and you don't roll it, the long-acting insulin, the NPH will all be precipitated and you'll get the clear insulin alone at the top. So if you inject initially when the cartridge is new, you'll find that you have post-meal hypos because you're injecting largely fast-acting insulin, and your pre-dinner and your fasting will be high. When the cartridge is finishing, most of the rapid-acting insulin is gone and you're left with the NPH. So you tend to get high post meals and hypos late in the evening and early morning because you have too much of the NPH dose. So you must tell the patient who's taking premixed insulin that they must roll the pen or the vial in between their palms and ensure that it is mixed into a uniform cloudy mixture. Only then must the insulin be taken. You'll be surprised how rarely people actually do this and how much of insulin fluctuation, blood sugar fluctuation can be avoided by this simple measure. Next slide. We do tell patients when we are teaching them first to take insulin about rolling, but then the majority of people are in a hurry taking insulin and they forget about it. Many patients complain that when they take insulin injections, they have pain and redness at the site of injection, and then they say they're not taking insulin anymore because it's very painful. Two of the commonest causes of pain and redness at the site of insulin injection is that if you inject the insulin, cold insulin straight from the fridge, if you're in a hurry, you take the insulin, it's still cold and you inject right away, it will cause pain and the site of the insulin injection will also be painful. The other thing is that you frequently need to change the needles. Normally, after about 4 injections, you need to change the needle. Otherwise, the needle tip becomes loses its sharpness, and then you tend to get pain and redness when you don't change needles frequently enough. Many people avoid changing insulin needles because needles are also expensive. They are not cheap. Next slide, please. Sharp disposal is another area I think we give very scanty attention to. We have had patients who throw their sharps in general garbage, which is very dangerous for people who are picking up the garbage. Some people don't know what to do with it. They burn it or bury it in the soil. And what should ideally be done is you should tell all your type 1 diabetic patients to collect sharps in a tin and then bring it to the hospital when they come for a review so that the sharps can be properly disposed. This again is an area that we tend to pay scant attention to. Next slide, please. Gauri wanted me to say a word or two about telemedicine for type 1 diabetes. In this time of corona, obviously, where patients are reluctant to come in, especially children, we are doing the so-called traditional, what's going on everywhere now, that is the telemedicine when patients contact us over Zoom or other means in order to have a consultation so that they do their blood tests locally and then have a discussion with us. And then that sort of consultation is there. But we are also looking at more long-term telemedicine solutions for type 1 diabetes. We have been looking at this for some years. There are 2 kinds of approaches we've used. One is to actually have a glucometer. You check your blood sugars regularly in the glucometer and then enter it through your phone. You need one of these smartphones to do that. And then it goes into a cloud from where the educator or nurse or the doctor can pick up the values. We have an engineering campus at Ettimade near Coimbatore, and some of the engineering students and staff there have actually made a low-cost glucometer. They've also included a chip in that through which, as soon as you do the blood test reading will automatically go into a cloud. So you don't have this problem of entering it through a telephone and all, because these children are not likely to be that diligent. So the moment they check, it goes to the cloud. And from the cloud, it comes to our computer. And there are alerts. You can decide the alert, hypo level, the hyper level, or if it is very high, so that as and when the readings come in, you can somebody can glance at it and then contact the patients as required, especially patients who are having fluctuating sugars and need close monitoring. This sort of thing is very useful. Parents also find this useful. We've actually done a pilot study on this even before Corona. And we found that parents are particularly happy because they feel somebody is actually monitoring the sugars on a regular basis. Because sometimes the child comes and tells them the sugar is low, they don't know what to do. Or the child says the sugar is high, then they say, okay, leave it today, maybe you ate too much. They really don't know what to do. So here they have the satisfaction that this is being monitored, and if it ever goes out of control, they will be contacted and given information about what to do. So this certainly is very reassuring. Next slide, please. I'd like I think I'm close to 20 minutes, so I will complete this very quickly. I think counseling for type 1 patients is a very important aspect of type 1 care. We do a lot of group counseling. When the type 1 patients are young children, controlling the diabetes is not very difficult because the children are very obedient and the parents take care of everything and the children will listen. But once they become adolescents, for a number of reasons, first of all, puberty and the hormones itself cause rise in blood sugars, and then adolescents have a whole lot of stresses and problems with examinations and love affairs, and diabetes is the last thing on their mind. So adolescents need special counseling. Caregivers also need special counseling because the caregivers have a lot of anxieties about type 1 diabetes, complications, are they doing the right thing? Will the children grow up normal? So what we have done is we usually do our counseling in groups, and for lack of time, I'll just tell you very briefly, we have a group of about 7 to 8 children who come in, or if it is parents or caregivers, then about 7 to 8 caregivers. And there is one person who will coordinate the session. And so initially I would open a discussion by, if I was the coordinator, I'd open the discussion by asking one of the children about how their diabetes is going and so on. So in the first 5-10 minutes of a 40-minute session, you'll find that you ask the questions and then the answers will come back to you. But sooner or later, somebody in the group will start asking or replying to a question, and then there will be more and more conversation between the children. or between the parents if it's a parents group. At that time, the coordinator just needs to take a back step and then leave it for them to discuss among themselves. You just need to make sure that no false facts are being raised or myths are being propagated in this, but because when they discuss among themselves, and you need to make sure that that doesn't go out of the topic and they don't start talking about cricket or the latest movies. So you just need to give it some direction. But otherwise, you'll find that when they talk among themselves, they open up in a manner in which they never do to medical professionals. And they learn off each other in a manner which our classes and our education sessions can never do. For example, the last session that I conducted, I had a young boy, the question about retinopathy came up and he said, I've been terrified ever since I heard that it might affect the eyes, but I've never had the courage to actually ask anybody, can it affect the eyes and will I go blind? But then now that this boy mentioned that he has a problem, I just want to ask him more about it. So you see, he doesn't feel that inhibition in asking another person about his concerns, whereas he would very much hesitate to ask a doctor or a healthcare professional the same thing. The last thing that I'd like to mention is these overnight camps that we do. Next slide, please. We take type 1 children and their parents for an overnight picnic. And usually other siblings also come along. So if we have 25 children, we usually have a group of 100 or more. And then we go and stay overnight somewhere. The vast majority of type 1 children and their parents do not know another person who has type 1 diabetes. Probably nobody else in their school has type 1 diabetes. In India, type 1 diabetes is relatively rare. So there's no one for them to interact with, no one to learn off, no one to get reassurance from. So these sessions are extremely helpful. That night, when we stay at the resort, you find that all the children before dinner are going to take insulin. So many of the children tell me for the first time, they actually feel normal. It's a normal activity to take insulin before a meal. Whereas otherwise at home, they feel they are the only person who takes it. They are the only person who's sick. So for the first time, it gives enormous reassurance. They exchange a lot of information about hypomanagement, about insulin, about a whole lot of things. So we do counseling sessions for the parents and arrange a lot of games. Next slide, please. And activities for the children. This is on a Christmas occasion, we arranged a Santa Claus. Usually we have professionals who come in from outside. Even movie stars, singers, they all come in and entertain these children. The children have a good laugh and dance with them. There are a number of games that we arrange for the children. And I must say, among all the activities that we have conducted for patient care, this is the one which has filled my heart the most. At the end of this program, you really feel a kind of inner satisfaction, which few things give you. I think that's my last slide, and I've already overshot time by 4 minutes. Thank you.
Sir, it was a very nice presentation, giving us lot of inputs on practical issues of managing type 1 diabetes. We have few questions. One is a Dr. Jayaraman. He has asked that he has got 6 of his type 1 diabetic patients are getting obese. So he has started on a low dose metformin of 125 milligrams of metformin BD dose. And now they have got good results, reduced insulin dose, reduces the weight also. And he has asked for your opinion on use of metformin in type 1 diabetes.
If your children are obese, I think you need to rule out whether they have type 2 diabetes or whether they're actually type 1, because we are increasingly seeing type 2 in children. If your C-peptide levels were close to 0 and insulin antibodies were positive and anti-GAD antibodies were positive and it's a pakka type 1, then certainly if the child is overweight and you can use metformin, you'll find that the doses that are required will come down. I think there are some clinical trials where other OHAs have also been added on to insulin, although it's not yet approved in practice, and it's been found that you can actually reduce insulin doses and get much better control rather than wild fluctuations in type 2 diabetics. Many of my diabetic patients at the time of puberty tend to put on weight, and then because of the pubertal hormones, and which are all increasing blood sugar, they tend to have uncontrolled blood sugar. At that time, I do add metformin temporarily, even in a classical type 2. And I found that it does help, even with the insulin that we are injecting from outside.
And another question is on give practical advice for SMBG testing frequency in a week.
Oh, for a type 1, it's very difficult to say. The more they test, the better, because they tend to have quite a few fluctuations in their blood sugar. I ask, it's always good to do a CGMS from time to time. Again, affordability is an issue, but for type 1, you must do a CGMS from time to time to make sure, because HbA1c is actually quite deceptive. An HbA1c of 7.3 doesn't tell you that occasionally the sugar may be going up to 350 and occasionally the sugar may be going down below 60. So we are also concerned about the variability. There may be a lot of variability in type 1 diabetics. That's something which we would like to avoid. So CGMS will bring out the variability, whereas HbA1c won't. But in general, I think you can certainly consider, sorry, what was the question again?
SMBG.
How many times we have to check the
SMBG, I think you should do, I usually ask my patients who can't afford CGMS to bring in blood sugar reports over the last week that they have done. And I ask them to do it at different times of the day. Many patients may be reluctant to do it multiple times the same day, although ideally they should. So then I tell them to do a fasting, a postprandial, a 7-point blood sugar check. Need not be the same day, at least they can do it at different times. So they do 1 or 2 tests a day and then bring the whole day's profile. So that gives me a good idea about how the sugars are and what sort of adjustments one needs to make in insulin.
Because the guidelines say ideally we should do 4 times a day, and it's
Ideally,
really difficult for many of our patients to go for 4 times a day. So we always somehow adjust between patient to patient. We individualize the checking rate. Thank you, sir.
I think it's not only the compliance, it's also the cost involved. Glucometer strips are not cheap. And if you check,
sir, and also the
quite expensive. Sorry.
The glucometer with that chip, which sends the readings to the cloud, is it available only to your patients from Amrita, or anyone can get the glucometer?
No, it's still under trial.
Okay, sir. And Amrita insulin pump also was there in trial. What is its present?
For both of those now, we have tied up with Wipro, which is probably better known as an IT company. But they have a part of their industry which develops these mechanical devices. So for both of these, we have an industrial tie-up with Wipro. So it's both of them are going ahead. Clinical trials are going ahead with both of them. So Wipro will be the industry partner who actually brings it out into the market.
Thank you, sir. And Madam Akila, Madam, and MSV, sir, do you have anything to add on this chapter?
Yes, yes, Dr. Gauri. That is, am I audible?
Yes, sir, you are audible.
Yes, sir. That is with reference to metformin. There is one group of patients with the type 1, that is idiopathic type. That is lack of beta cell autoimmunity, lack of HLA antigen relation. So such patients, their age of onset and their body mass index, their visceral adiposity is totally different. They may present with hypercholesterolemia. They appear obese, and such patients can be managed with insulin as well as metformin. And we do come across patients, family history of type 2 in that case also. Of course, we normally check the C-peptide levels in the fasting as well as postprandial. Of course, more often we check the postprandial C-peptide value rather than the fasting C-peptide value, with a view to actually look into the beta cell capacity to secrete insulin on time. That is one. Second thing is with reference to SNBG, we normally tell Monday you check early morning fasting, and Tuesday you check 2 hours after post breakfast, and Wednesday you check after lunch, and Thursday you check after dinner, and Saturday you will be at home, wherein you can also have a check on 12 midnight and 3 a.m. just to see whether the therapy what we are advising is able to control the sugar in the day as well as in the night time, in order to minimize the cost of the follow-up therapy. That's what we normally tell them.
Yeah, absolutely.
And one
I think
thing,
that 7 point is very essential.
Yes.
Only then you'll get a complete picture.
Yes.
Yes, yes. Provided the meal time is very constant and the patient take the diet at the appropriate time, as well as they follow our advice very strictly.
Thank
Can
you.
I add a point?
We'll have a lot of questions on this subject, because everybody has many practical issues in the insulin injection dosage, insulin injection sites and all. We'll close the session right now. And
Can I add a point?
Dr. Akila, she wants to convey something.
95%, I have 400 children with type 1 diabetes. 95% of my children do 4-time blood sugar checks every day. As sir said, actually the education is the pillar of treatment of type 1 diabetes. All my patients know how to adjust their therapy, and almost 95% of them do minimum 4-time checks every day. If they cannot afford strips, I will find ways to supplement strips. I might pay for it myself. I will get friends to pay for it. Somehow I will give the strips to the children. And 95% of my patients are on 2-day checks every day.
Sir, how the use of CGMs in your patients? How frequent?
Very, very low, because they're all happy with their glucometer and blood sugar checks. All of them have a notebook. They cannot come into the OP without their notebook. So everybody, whether they write, most of them even maintain their food charts along with the blood sugars and the insulins. But at least I say, even if you cannot write your food, after the initial 2-3 months, they will know how to adjust. So it will be blood sugars and insulins, and without the notebook, they cannot enter the OP. Even if they don't pay money, that is fine. But without the notebook, you cannot come to the OP. Excuse me? Yes, Dr. Gauri. You had a question.
No, madam.
Thank you.
Thank you, ma'am. Thank you, ma'am. We'll finish the session now. And we have a nice video by Velavan Harish, one of our diabetic type 1 child. Hope you'll enjoy this video.
Very good morning to all. I am R. Velavan Harish, studying 5th standard, residing at EB Road, Trichy. It's okay to be type 1 diabetic by following healthy and happy diet. As per doctor's advice, I am checking my insulin level daily and taking insulin before food regularly. We are not different from other kids. Just we need some extra care in our food habits with prescribed dosage of insulin. Rather than I am living happily, enjoying my life along with my family members and friends. So stay healthy and stay safe. Thank you all.
I think it's a nice video, and there's energetic for other pediatric diabetic patients. Thank you, Kutipaya. Our next speaker, energetic and eminent speaker, Dr. M. Shanmugailu sir, is a chairman and managing director of Trichy Diabetic Specialty Center. Sir is the secretary of RSSDI, Research Society for Study of Diabetes in India, in Tamil Nadu chapter. Sir has done his MBBS and MD in Kilpauk Medical College, Madras University, 1980 and 1985 respectively, and FRCP at Glasgow, UK at 2015, and FICP is Indian College of Physicians 2016. And he has published articles in various journals and contributed topics to textbook of diabetes mellitus. And Sir has presented papers in various forums and has participated in the phase 3 and phase 4 clinical trial and epidemiological studies as principal investigator. Sir is honored with Professor Dr. Sam G.P. Moses Oration Award and Economics Time Inspiration Diabetes of India Award and Topicon 2018 Dr. Arul Raj Guest Lecture Award. And Sarah is going to give a talk on what is the horizon for type 1s, the latest in diabetics research. Sir, over to you, sir.
Am I audible? Dr. Kauvery, am I audible? Can you see my slides very clearly?
Yes, sir.
Yes, there is no problem. Yes. Respected chairpersons, guest speakers, Dr. Kauvery, Dr. Sengitwan, and other members of Kauvery Hospital and learned viewers and listeners of this program, I feel extremely happy, honored, and most privileged to have been invited to make a presentation on what is on the horizon for type 2 diabetes, the latest in diabetes research. My particular focus is on improving quality of life in patients with type 1. So I thank Dr. Kauvery and his team members for inviting me to be a faculty for this program. I also thank the chairperson for the generous introduction. My disclosures, what I'm going to do for another 20 minutes. What is on the horizon for type 1, the latest in diabetes research? The contents of my top line include introduction, advances in the management of type 1 diabetes with reference to metformin, SGLT2 inhibitors, advances in insulin pumps, continuous glucose monitors, closed loop systems, insulin gene therapy, transplantation, of course, immunological vaccine, and conclusions. So the burden of complex management of diabetes and the complications is associated with significant risk of psychological and physical morbidity for those affected by constant and chronic conditions. Prior to the past 20 years, individuals with the type 1 were managed with multiple daily injections of insulin guided by SMBG by regular finger stick. Next, since the introduction of insulin pumps and continuous glucose monitoring, increasing number of individuals are using these systems. However, their use is limited by cost and individual factors. For individuals who continue multiple daily injections, improvements in injectable insulin may be of benefit. So what do we know about type 1? It's a chronic autoimmune disease resulting from the destruction of beta cells of the pancreas. Its pathogenesis can be divided into certain arbitrary phases, including a genetic predisposition, environmental triggering, and an asymptomatic phase. If you look at the genetics, complex, more than 20 loci will to be involved. The most important of these actually class 2 genes in the region of DR and DQ, especially DR3 and DR4. Environmental triggers include viral infections, the congenital rubella or coccidioides virus, diet. Of course, it is a controversy. Islet autoimmunity develops specific T cell responses against islet antigen. We have the various cytokines and nitric oxide, which are important in promoting beta cell destruction. Immunotherapy trials are currently being pursued to help prevent or ameliorate the immune response against beta cells with variable success. So what does the type 1 diabetes scenario look like nowadays? So very important thing is genetically predisposed individuals. They are exposed to a triggering event. That triggering event induces inflammation and upregulation of major histocompatibility, that is MHC molecule in the endocrine cells. So next is autoantibodies against islet antigens appear in the circulation. And in this stage, the blood sugar levels are normal. There are no confident symptoms of the disease. Very important thing is the T cells proliferate, infiltrate the beta cells, destroy the beta cells, and infiltration becomes apparent during the pre-diabetic state as well. And very important thing is the dysregulation of glucose happens in the pre-diabetic state. And very important thing is post-translational modification might arise as a consequence of endoplasmic reticulum stress and inflammation, potentiating the activation of the T cell on the beta cells. There is a fluctuations in the levels of the beta cell survival as well as beta cell death. And very important thing is this can expand into a diabetic period as inflammation is still present. Subsequently, there is a progressive destruction of the beta cells. So also the beta cell population mass diminishes, so do inflammation and infiltration, resulting in the full blown. And very important thing is in the early stage, the C-peptide levels are detectable. So for our clinical purpose, we have the stage 1, stage 2, and stage 3. So stage 1, 2, 3, beta cell autoimmunity present in all the stage. There is beta cell loss, and very important thing is plasma glucose normoglycemia stage 1, hyper in stage and 2 and 3 stage, and symptoms absent in stage 1 and stage 2 and present in stage 3. So what are the potential targets for therapeutic intervention in patients with the type 1? That is very important thing is we have the genetic susceptibility and we have the environmental factors with reference to viral infections, with reference to diet, and very important thing is primary prevention. And next is appearance of islet antibodies, and we have the secondary prevention, and we make a diagnosis of type 2 diabetes. And what is primary prevention? That is prevention of beta cell autoimmunity from developing in susceptible individuals. That is, we need to conduct a genetic screening at birth and enroll infants with a genetic risk of type 1. So if a father has type 1 diabetes, the chances of inheritance in the offspring is 10%. If a mother has type 1 diabetes, the chances of inheritance is 3%. So based on this, we can do genetic screening, and if possible, we can do primary prevention provided it is accepted by the patient. Next is secondary prevention trials, modulating the immune response against beta cell after beta cell autoimmune process is activated. So this involves following a birth cohort with a genetic risk until signs of autoimmunity. They develop or screen for autoimmunity amongst the first degree relatives of individuals with the type 1. So do the screening with reference to autoimmune markers of beta cell like intracellular cell cytoplasmic antigen or GAD antibodies or in autoantibodies to insulin like that. So tertiary prevention, slowing the rate of loss or halting the destruction of beta cells after diabetes has supervened. Right. So key message from trials for prevention of type 1, whether it's primary or secondary or tertiary. Numerous interventions have been shown to prevent or reverse immune-mediated diabetes in animal models. None has been unequally successful in clinical trials in humans, either to prevent type 1 or to stabilize beta cell function over a protracted time frame. So nevertheless, some human studies have demonstrated transient beneficial effect without major safety concerns. So they may be effective for a short period of time, but this is associated with side effect profile. And what is very important thing is the sustainability is very much lacking. So major safety concerns thus raising the prospect of combination. So induction of remission and maintenance of remission for a little longer period of time is very much lacking. So what is on the horizon for type 1, the latest in diabetes research? So in the beginning, Banting and Best discovered insulin in 1921. So we are going to celebrate the 100th year next year. So scientists have continued to improve the types of insulin, making them mimic physiology more closely in order to minimize hypoglycemia. Of course, we are injecting insulin in the subcutaneous tissue. It is drained by a separate system, whereas beta cells, they release insulin into the portal circulation, cannot exactly mimic. However, we can improve the technology in order to improve the glycemic control, as seen with the latest insulin analogs. In the same manner, the delivery process of insulin has also continued to evolve to make it easier and more acceptable to patients. So meeting patient needs, this was highlighted nicely by Professor Dr. Harish Kumar. So patient-centered care, an approach to providing care that is respectful of and responsive to individual patient preferences, needs, values, and ensuring the patient values guide all clinical decisions with reference to complications, glycemic control, certification of severe risk factors, self-management, adherence, quality of life, and be the team members centered around the patient, primary care physicians, assistants, dietitians, database educators, nurse practitioners, social and caseworkers. So many countries use systems of integrated care by multiple providers to manage all disease aspects. So next is non-optimized clinical outcomes may be due to non-integrated tools and fragmented care. That is also highlighted nicely by Dr. Professor Harish Kumar as well as Dr. Akhila Yavu. So tools for glycemic management are not aligned. Fragmentation of care for individuals with the diabetes is a problem. So sophisticated management using multiple non-integrated tools by multiple providers might not be financially sustainable or lead to the very best clinical outcome. So simplification of disease management and better integration of care is very much needed or required. So managing hyperglycemia, early optimization of glycemic control, achieving and maintaining optimal levels of glycemic control within a few months after making a diagnosis with reference to A1C, with reference to fasting plasma glucose, with reference to postprandial plasma glucose, minimizing the glycemic variability and minimizing the risk of hypoglycemia, minimizing the weight gain also. So optimization of glycemic control at an early stage of the disease, that's the most fundamental aspect of care in management of type 2 for preventing micro and in the long run macrovascular complications. So hyperglycemia is a strong risk factor for macrovascular complications like retinopathy, neuropathy, and nephropathy, whereas it is one of the risk factors for macrovascular complications. It is often associated with multiple risk factors, and that hyperglycemia amplifies the risk for macrovascular complications. So this particular trial, DCCT, and subsequent follow-up EDIC trial, patients were randomized to intensive arm and standard glucose control arm. Patients in the intensive arm, they experienced the benefit in terms of early glycemic intervention with reference to microvascular complications. When those patients were followed up for a period, the patient continued to experience the benefit not only with reference to micro in the long run macrovascular complications. So it takes many long years to observe the cardiovascular benefit of improved glycemic control. So the basal bolus insulin concept, which is physiological, ideal, and we need to properly educate the patient. We need to motivate the patient in order to improve the quality of life as well as sense of well-being. So basal insulin contains constant low-level secretion for 20 hours and suppresses glucose production between the meals and overnight. And we need to provide 50% of daily needs basal insulin. And bolus insulin is secreted in the two phases, phase 1 and phase 2, which limits hyperglycemia after meals. So it is able to control the prandial glycemic excursion. So it's a prandial glucose regulator. Immediate rise and sharp peak at 1 hour, and we need to provide 10 to 20% of the total daily insulin requirement before each meal. So we have the different category use of insulin: rapid acting, short acting, long acting, intermediate acting. These are the various brand names. And the time action profile is given in this panel. And rapid acting with reference to onset of action and the time to reach maximum. Short acting begins after 30 minutes after subcutaneous injection. Some long acting beyond 24 hours M2. So nowadays we have the ultra long acting basal insulin, which can be given once daily, in contrast to twice daily. NPH insulin we used to give those days. And peak onset is also given, and the dosage depending upon the type of insulin we use. So what are the advances? Presenting a brief overview, recent advances with reference to newer insulin delivery options, hypoglycemia prevention through use of technology. That is very important. Sarah has told a story that is patient presented with severe hypoglycemia and fits. So recent advances in continuous glucose monitoring system, closed loop system, insulin analogs, gene therapy, transplantation, and immunological vaccination. So advances in the management with reference to drug therapy. So the current National Institute NICE guidelines for the management recommend consider metformin in adults with type 1 and body mass index greater than 25 kg per meter square who want to improve glucose control while minimizing the effective insulin dose. And ADA also recommend adding metformin to insulin therapy, which may reduce insulin requirement and improve metabolic control. And these recommendations are based on relatively limited amount of evidence that you should always bear in mind. So removal was the first large multi-center double-blind placebo control study of metformin in patients with the type 1. In this metformin group, there was no significant improvement in the primary endpoint of carotid intermediate thickness or the second endpoints of insulin dosing or glycemic control. And metformin does not seem to make meaningful improvement in several important outcomes. But when added to insulin, that is associated with modest improvements in LDL cholesterol, weight, and kidney function. Next is SGLT2 inhibitors. Mechanistic effects linked to renal and cardiovascular benefits of SGLT2 in patients with the type 2 have also been documented in patients with the type 1, including patients without diabetes also. So kidney protection, SGLT2 inhibitors, it reduces blood glucose level. We know the site of action of SGLT2 inhibitors. It reduces albuminuria, reduces inflammation. At the same time, it also reduces volume overload, blood pressure, body weight, and weight with a favorable impact on kidney as well as heart protection. So safety of SGLT2 in type 1, the treatment with reference to author and canagliflozin 300 milligram or 100 milligram compared to placebo, no difference. And very important thing is genital infections very high, urinary tract infections, and volume depletion. So dandona, dapagliflozin 10 milligram, 5 milligram compared to placebo, no difference between the treatment and the placebo. And GARD, Satish GARD, sotagliflozin 400 milligram compared with placebo, no difference between the treatment. So advances, we get the short-acting insulin, that is insulin Lispro, Oxford, Glulysin, long-acting insulin with reference to glargine, detimir, degludec, and of course, glargine 300 IU, and we have the inhaled insulin. So glargine approved in children aged 2 years and above. It's the first long-acting basal insulin analog introduced into clinical practice, and that is the only basal insulin with established long-term CV safety proven in Origin trial. And insulin degludec shows a flat profile. So the pharmacokinetic and dynamic profiles of glargine, 100 IU, 300 IU, and ultra long-acting basal insulin analog, namely degludec, or different. They are flat, never peaks at all, and the pharmacokinetic dynamic property is very important while prescribing, and it is available as dihexamer in the insulin delivery device. When it is injected in the subcutaneous tissue, it undergoes molecular rearrangement with the formation of multihexamer that slowly release monomer into the circulation with a long duration of action. So inhaled insulin, Exubra approved in 2006 but withdrawn from the market. Aprisa, US approval in 2014. Human insulin is available as inhalation powder, and very important, patient with the type 1 must use with a long-acting insulin available as a single-use cartridge, that is 4 units and 8 units. So these are all the insulin delivery modes. So from the time-tested syringes, Sarah has nicely pointed out 100 IU and 40 IU. With improved technology, we have the disposable thin needles and more sanitary. And next is insulin pumps and devices, ease of handling and more discreet, so user-friendly. And we have the jet injectors, that is sends insulin through the skin using high pressure mechanism, an option for people with a severe needle phobia. Right. Next is insulin pump, that is Dr. Arnold Kadish in 1963 with the first insulin pump. It was replaced by the Big Blue Brick, and today we have insulin pumps that are convenient, small, accurate, and adjustable. And we have the external insulin pumps, and which provide basal amount of insulin continuously throughout the day. And pumps can also give bolus doses, one-time larger doses of insulin at meals, and at times when blood glucose is too high. So we can adjust bolus insulin, and we can also adjust the infusion rate of basal insulin. And Dr. Krishnan Swaminathan, he will touch upon his lecture on the pump. So more physiological insulin delivery and basal, bolus, spots of insulin to cover the carbs or lower or high blood sugar level. And basic principle is this allows for precise insulin dosing according to each individual's requirement. Insulin pumps use rapid-acting insulin analogs to meet the individual's basal and bolus requirements. And due to enhanced absorption, insulin doses are reduced by 20 to 30%. If the patient is receiving 60 units, we need to reduce the dose by 20 units. The amount by which the dose is reduced depends on the most recent glycated hemoglobin. Approximately 50% of the total daily insulin is used as basal and 50% as bolus insulin. And insulin is programmed to be delivered continuously on an hourly rate, aims to mimic normal insulin production of the pancreas. And infusion rate is often programmed to change at various times during the day, with the aim to keep blood glucose levels stable and keep the time in range between 70 to 180. And by keeping the time in range, we can minimize the hyperglycemia or hypoglycemia. And very important thing is we can minimize the risk of diabetes-related complications, namely retinopathy as well as microalbuminuria. That is, we need to achieve and maintain 70% of 24 hours, that is 16 hours and 48 minutes a day. And increasing the duration of time in range has been associated with the reduced diabetes-related complications. And decrease in the time in range has been associated with increased risk for diabetes-related complications. So delivering basal insulin by an insulin pump allows a flexible approach. And bolus insulin is delivered to correct an elevated blood glucose level or to manage glucose level based on the insulin to carbohydrate ratio or based on the insulin sensitivity factor. So these are all the advantages. Insulin pump use and low cost, all cause mortality. This has been demonstrated in an observational study, and the meta-analysis controlled trials demonstrated a significant reduction in time spent in hypoglycemia with the pump therapy. So we can minimize the risk of hypo and hyperglycemia as well as the blood glucose variability, thereby the development of microvascular complications. Pump use is also associated with improved lifestyle flexibility, quality of life, and satisfaction with the diabetes treatment. So statistically significant improvement in A1C with pump consistently demonstrated in clinical trials, and this must be considered in the context of significant reduction in hypoglycemia seen with pump therapy. So pumps offer more normal lifestyle, that is liberalization of diet, increased control with exercise, able to work shift and through lunch, and less hassle with the travel and time zones, and gait to weight control, and less anxiety in trying to keep on schedule. And these are the disadvantages, costly and out of reach financially, and maybe inappropriate, challenging for some people. And multidisciplinary approach is very much needed. And the risk associated with insulin pump, including pump failure and line issue, and they are not infrequent, and patient needs extensive education. And infusion site reactions such as lipohypertrophy can occur, and these reactions can often be managed effectively with simple strategies. And we have the sensor augmented pump, a little improvement in the technology. This refers to automation of insulin delivery by an insulin pump with concurrent use of an insulin pump and a CGM system, and switching from optimized multiple daily injections of insulin to sensor augmented can result in significant improvement in A1C without an increase in hypoglycemia. So this plays an important role in those individuals having brittle diabetes in this form. We used to say that is patient presenting with very high very high range of blood glucose level or very low levels of blood glucose level. So the addition of predictive low glucose management system results in less time. And these are the reductions in duration of hypoglycemia by automatic suspension of insulin delivery. Automatically the pump stops the insulin infusion rate for 2 hours. That is low suspend glucose and low suspend. And this is a future. And next is meter talks to pump, the paradigm infusion pump. And of course, pump is metered. So pump has been incorporated with the meter also. So the pump and meter combination, the direct glucose entry into database eliminates the data error, and we have the various combos. And next is Guardian Auto system. We have the sensors here, we have the transmitter pod, and we give the monitoring, and we can adjust the bolus insulin as well as basal rate. So pumps have come a long way, and we have the continuous glucose system, the basic principles, and the traditional works by placing the small electrode into the interstitial fluid. And as pointed out by Professor Dr. Harish, CGM enables the generation of an ambulatory glucose profile, which assists in guiding management, overcomes limitations in A1C as a measure of glycemic management, improvement in glycemic management. And very important thing is, especially while managing patients with the type 1 during pregnancy, has been shown to be associated with improved neonatal outcomes. This Freestyle Libre Pro, that is the only device currently available for this purpose. And we have the sensor, and scanning of the sensor by a reader device, it can give the actual interstitial glucose level also. And this flash glucose monitoring was compared with self-monitoring blood glucose. And we have the various parameters with reference to self-monitoring blood glucose, continuous glucose monitoring, as well as flash glucose monitoring, with reference to glucose measurement, calibration, finger prick, and duration of sensor use, data updated, hypoglycemic alarm, connection to insulin pump, and connection device. Right. And this is a glucose monitoring. That is ancient method, and we have the modern method. And the continuous glucose monitors, there is an important aid in the management of type 1. And very important thing is superiority over self-monitored glucose in reducing. And we have the glucose sensor in the interstitial space, which sends through a wireless transmitter to the receiver. And these are the devices for blood interstitial glucose monitoring, comparison of main features with reference to blood glucose meters with finger prick, and blood glucose meter with overall ability for ketone bodies, and continuous glucose monitoring with an insulin pump, and the flash glucose monitoring system. Right. So continuous glucose monitoring is a non-invasive CGM device, and this is an improved version. The principle of Raman spectroscopy, where a painless pulse of monochromatic light is transmitted in the skin, and the scattered light is detected for the determination of glucose levels. That is yet another improvement in technology. And glucose meters used to check blood glucose levels, and many different types and models we have. And this glucose monitoring, that is home blood glucose monitors, this measures the glucose in whole blood. And of course, plasma glucose levels are generally 10 to 15% higher. And most of the modern meters on the market give the results as plasma equivalent. And we have the closed loop system. And we have the continuous glucose sensor, we have the control algorithm, and we have the insulin pump here. So the backbone of the closed loop system, that is a control algorithm. This control algorithm direct insulin delivery as per the glucose levels and according to measurement. So the continuous glucose sensor, it provides the levels of the glucose accordingly. The control algorithm directs the insulin pump to deliver insulin. And we have the two categories of control algorithm: proportional integral derivative and model predictive derivative. So we have the closed loop system. Still needed faster insulin, better CGM accuracy, and less sensor lag time, and the glucose control algorithm that won't fail. And we have the innovations in closed loop system. We have the intraportal or intraperitoneal insulin infusion to mimic the natural secretory pathway. However, this invasive procedure involved in placing the device at the risk of infection. And we have the low glucose suspend, that is another feature to combat hypoglycemia, as the pump would automatically stop insulin infusion for up to 2 hours and restore and resume its function. So the gene therapy, that is a fancy word. Insulin gene therapy, it envisages introduction of insulin secretory machinery in non-beta cells. So effective gene transfer system, regulatory system, biomechanical machinery for processing and appropriate target cells. We have the transfer system can be achieved by viral or non-viral factors. And of course, we need to have the glucose response to insulin production. So transplantation, and we have the pancreas transplantation. So the pancreas transplantation alone, and pancreas after kidney transplant, or simultaneous pancreas and kidney transplant. We have the islet cell transplant, and we have the stem cell therapy. Of course, we have the xenotransplantation, which offers exciting prospect, that is transplanting porcine islets into human patients of type 1, which was carried out in 1994. And this particular trial demonstrated detectable C-peptide levels in patients as well as in urine for up to 300 days. And these studies provided strong clinical benefits for treating patients with type 2. And number of challenges limit the clinical implementation. And we need to provide neonatal porcine islets like cell pancreatic cell clusters as opposed to mature islets. And after transplant, the encapsulated cells are reported to proliferate and differentiate into mature cells, providing robust glucose control. So we have the islet transplant, the efficiency and consistency and islet isolation procedures and care very much needed. So we have the Edmonton protocol, and these are the procedures for human pancreatic islet that involves several stages. And donor pancreas is harvested, preserved, purified, they are cultured in vitro. And next is there is encapsulation strategy where islets for transplant are physically protected from patient's immune responses. There are many encapsulation approaches, and these comprises stem cell derived pancreatic progenitor cells, and these results indicate the safety and tolerability with reference to the encapsulation product candidate when delivered at subtherapeutic dosage. So sources of progenitor and stem cells, we have the adipose derived mesenchymal cells, bone marrow derived cells, and other cells. So these cells are known as other stem cells. They are highly multipotent. They are known to differentiate into several specialized cells, including the vascular pericytes. And stem cells have gained attention due to their potential for providing glucose response to insulin producing cells. They enhance therapeutic options. And these are the clinical applications of endocrine specific cells. Still, research in the field is expanding with much of the expectations to obtain final destination. So the future strategies for successful outcome of human islet cells: donor, recipient, conventional therapies, encapsulation, stem cells, and xenotransplant. These are the list of prominent clinical trials utilizing different interventions. And these are the immunological vaccines given orally, that is insulin. It has an immunomodulatory effect. So in short, CGMs have real-time monitors with alarms connected to smartphones and to more non-invasive methods. Closed-loop systems are developing to stimulate the pancreas, and newer insulin analogs have more predictable half-life and activity. Islet cell transplantation is also continually transforming to reach the point of complete cure, and immunological vaccine is in its nascent stage. So, my beloved doctor friends, please remain safe, take care, stay healthy, protected, and connected in the days to come. Now, I'm going to stop sharing my screen. Thank you very much once again to the organizing committee members of this program.
Thank you, sir. It was a very elaborate and clear presentation on the recent developments in type 1 field. And before that, I would like to welcome Krishnan Swaminathan, sir, to this forum. Welcome, sir.
Thank you. Great, ma'am. Nice to see all of you. Dr. Shinmugavelu, nice to see you after a long time.
Yes, sir.
And Gauri, madam, first time seeing you. Great to be here.
Thank you, sir. Thank you, sir. You're welcome, sir.
The thing is, he will touch upon many aspects of insulin pumps, what I have left in this period.
Thank you.
So, and this is little out of the topic question. Your comment on the incidence of type 1 diabetes in the post-COVID era.
Type 1?
Diabetes occurring in children after COVID-19 infection, post-COVID, type 1, there are case reports coming.
No, I will not say patient has evidence of type 1 or type 2. That is, ACE2 transporters are expressed in both exocrine as well as endocrine tissues of the pancreas. They are upregulated, number one. Their activities are very high. So these cells, these transporters induce damage of the pancreatic endocrine as well as pancreatic exocrine cells. So patients present with hyperglycemia, with high blood sugar levels. So we manage the patients with insulin for a short period of time. When you do anti-GAD antibodies, negative, and there is no family history of diabetes, So presentation is development of diabetes-like picture following the SARS-CoV-2 infection. Its effect on the exocrine and endocrine tissues. We need to follow such patients. So we cannot categorically say this belongs to type 1 or type 2.
Okay.
Right.
So another question is from the audience, what will be the cost of freestyle LIBOR CGM sensor and monitoring device? That of course is 2,000 rupees.
It comes 2,000 rupees, 1,800. And you can put it and you can allow it for 14 days and then collect these sensor and connect it to a laptop or a desktop and get the graphs and see the time in range, time above the range, time below the range. And of course, we have the national as well as international guidelines for maintaining the time in range. I told you during my presentation, time in range, we should achieve 70% of 24 hours. That is 16 hours and 48 minutes. By that, we can able to achieve, minimize the glycemic variability, minimize the risk of hypoglycemia, minimize the risk of hyperglycemia more so in the long run, diabetes-related complications.
Thank you, sir. With this, we are concluding the third session of today's webinar, and we'll move on to the most awaited topic on practical issues with insulin pump therapy. And over to Dr. Vignesh and Meghnadhan to introduce the speaker.
Very good evening. Our next speaker for this webinar is Dr. Krishnan Swaminathan. He is currently a consultant endocrinologist at Kauvery Medical Center, Coimbatore. He has completed his undergraduate medical education from Madras Medical College, and he's completed his higher specialist training in diabetes and endocrinology from renowned centers in UK, including London, Cambridge, and Scotland. He has published over 70 publications in the international journals. He's the funding trustee of Idayangal, that is a registered charity that he has funded more than 3 crores for various charitable causes, especially for poor children with type 1 diabetes in India. He's the author of the best-selling easy-read Tamil book, Samaniyanum Sakre Noyum. Today also, he is going to talk about the common topic, the Coimbatore model of insulin pump therapy for the rural unprivileged, making the impossible possible. Over to you, sir.
Thank you. Thank you. Voice every clearer, ka?
Super, sir.
Okay. Screen share panetta?
Yes, sir.
Screen is clear?
Yes, sir. Yes, sir. Slide show, please, sir.
Great. Ellarukkum panivana maalai vanakkangal. First, it's just such a pleasure to be a part of this program. Dr. Gauri Madam, thank you very much for the invite. And topic is super engalukku pidichu kuduthinga. KMCH oda logo வந்து making impossible possible. So I think working in KMCH it works well. நான் வந்து ரொம்ப எனக்கு லாஸ்ட் டாக் 138 பேர் பார்ட்டிசிபென்ட் இருக்கிறது பெரிய விஷயம். ஆனா சாட்டர்டே ஈவினிங் எல்லாம் வெறுத்து போய்
ஸ்பீக்கராவே போட்டுருக்கோம்.
Thank you madam, but I'm sure எல்லாரும் போறதுக்கு ரெடியா இருப்பாங்க. நான் வந்து ரொம்ப மருத்துவம் பத்தி பேச போறது இல்ல, கொஞ்ச நேரத்துக்கு கொஞ்சம் philosophy பத்தி பேச போறேன் நானு. அதனால ரொம்ப பம்ப் தெரப்பியோட இன்ட்ரிகசிஸ் பத்தி நான் பேச போறேன்னா டிசப்பாயிண்ட் ஆயிடுவீங்க நீங்க. ஃப்ளோ ஆஃப் பிரசன்டேஷன் அடுத்த 20 நிமிஷத்துக்கு இந்த வலி நமக்கு தெரியுமா? What is it for a child and their family, especially coming from a poor socioeconomic status, to have type 1 diabetes? நம்ம மருத்துவர்களாக அந்த வலியை புரிஞ்சுக்கிறோமா இல்ல புரிஞ்சுக்க முயற்சி செய்கிறோமா என்பது முதல் கேள்வி. அண்ட் எப்படி இந்த சோசியோ எக்கனாமிக் பேரியர்ஸ் அண்ட் டயபிட்டிஸ் டெக்னாலஜி, இப்ப நம்ம ஃபேன்சியா பம்ப் எல்லாம் பத்தி நிறைய பேசலாம். ஒரு மிஷினோட விலை லோவஸ்ட் மாடல் இஸ் 2.2 lakhs இப்ப 722 பம்ப். இதை எப்படி ஒரு சாமானியனுக்கு பொருத்துவது, எவ்வளவு ஃபேன்சியா பேசினாலும். அண்ட் கொஞ்சம் அவுட் ஆஃப் த பாக்ஸ் திங்கிங்ல வந்து நம்ம கோயம்புத்தூர் மாடல் பத்தி பேசுறேன். Because we are trying to make the impossible possible. We are trying to break socio-economic barriers in diabetes technology. சில கவலைப்படக்கூடிய நம்பர்கள் இது. நான் வந்து KMCH டேக் ஓவர் பண்ணும்பொழுது 150 children இருந்தாங்க 5 years ago. Now we are having 500 plus children with type 1 diabetes under my care, 520 as of today. And Coimbatore districts மட்டும் 1000க்கு மேல இருக்கு. 1 to 1.5% school going children in Tamil Nadu. And ஒவ்வொரு வாரமும் 2 லிருந்து 4 new patients with DKA நான் பார்த்துட்டு இருக்கேன். And it's an underestimate, 1.3 lakh in India. Numbers are increasing by about 3 to 5% per annum. இது எனக்கு ரொம்ப பிடிச்ச ஸ்லைடு. இது ஏன் ஒரு செல்ஃபினா அடுத்துன்னு எனக்கே தெரியல. இது KMCHல நான் 4 வருஷத்துக்கு முன்னாடி ரொம்ப நூலா போய் ரீனல் ஸ்டோன் வித் யூரோசெப்சிஸ்ல அட்மிட் ஆயிருந்தேன் நானு. தலைவலியும் கால் வலியும் தனக்கு வந்தால்தான் தெரியும். ஓகேவா? ஸோ இது எங்க நாய்க்குட்டி. அண்ட் இது எதுக்கு போட்டிருக்கேன் அப்படின்னா, போன வாரம் காலையில ஒரு 6 மணிக்கு பயங்கர சத்தம் பார்த்தோன்னா ஒரு கட்டெரும்பு என் நாய்க்குட்டி அம்முவின் காலை கடித்து கொண்டிருந்தது. அண்ட் ஒரு 10 நிமிஷம் ஆச்சு அந்த எறும்பை எடுக்கிறதுக்குள்ளார. அரை மணி நேரம் என்னோட குட்டி துடிச்சு போச்சு. அண்ட் அதை பார்க்க நம்மளால் முடியவில்லை. இதை எப்படி நமக்கு நம் நாய்க்குட்டிக்கு இவ்வளவு ஒரு கஷ்டம் வரும்பொழுது நம்மளால் பார்க்க முடியலன்னா, ஒரு 1.5 வயது குழந்தை என் பெற்றோரிடம் போய், நீங்கள் ஏற்கனவே டயபெட்டிக் கோமால அட்மிட் ஆயிருந்தது இந்த ராகவர்தனிங்கிற குழந்தை, 4 வேளை இன்சுலின் வாழ்நாள் முழுவதும் போடணும் என்று சொல்லும் வழியை ஐம் ஷூர் நீங்க எல்லாரும் நம்ம எல்லாரும் பார்த்து கொண்டிருக்கிறோம். And this is a real pain to tell a parent that உயிர் பழச்சிச்சுங்க எனக்கு இன்சுலின் ஊசி லைஃப் லாங்கா போடணும் அப்படின்னு, எஸ்பெஷலி ஒரு ஏழை குடும்பத்திலேருந்து வரும்பொழுது. This kid actually survived a very major ICU admission. She was declared dead in a nearby hospital, and now she's 4 years doing really well on basal bolus regime. And இந்த வலி எப்ப எனக்கு தெரிஞ்சதுன்னா, நான் யூகேல இருந்து மதுரை வந்த முதல் மாதம் இந்த அர்ஜுன் என்ற பையன், இந்த அர்ஜுன்கிற பையன் வந்து அகெயின் வந்து ஸ்டேட் ஹாஸ்பிட்டல்ல இருந்து இறந்து விட்டான் என்று வீட்டுக்கு அனுப்பப்பட்ட பையன். அப்பா அம்மா ரொம்ப புவர் ஃபேமிலிஸ், இவங்க இன்சுலின் வாங்குறதுக்கு பணம் இல்லை. அந்த 2-3 நாள் கவர்மெண்ட் சப்ளை ஆக்சஸ் பண்ண முடியல. சுகர் 700-800 போய் சிவியர் டிகேஏ. அண்ட் ஆட்டோல இந்த பையனை வீட்டுக்கு அழைச்சிட்டு போறாங்க ஃபார் ஹிஸ் ஃபைனல் ரைட்ஸ். அண்ட் அப்ப நான் அப்போலோல இருந்தேன். அந்த அப்பா என்ன நினைச்சாரோ தெரியல, கடைசி நேரத்துல ஜஸ்ட் அப்போலோ எமர்ஜென்சிக்குள்ள விட்டாரு. ஸோ கார்டியக் அரெஸ்ட் கால். திஸ் கை வாஸ் இன் பெரிகார்டியக் அரெஸ்ட். அண்ட் பின்னாடி நீங்க பாக்குற போட்டோ அவங்க அம்மா. அந்த அம்மா அன்று காலில் விழுந்தார்கள். எனக்கு அவனுக்கு அடுத்த 2வது நாள் அவனோட பர்த்டே. ஆனா அந்த அம்மா சொன்னாங்க, டாக்டர் என் பையனின் பிறந்த நாளும் என் பையனின் இறந்த நாளும் ஒரே நாளா இருக்கும் போல இருக்கு டாக்டர். இறந்துட்டான்னு சொல்றாங்க, நீங்க எதாவது பண்ண முடியுமா? இங்க பண்ண முடிஞ்சாலும் எங்க கையில காசு இல்லை அப்படின்னாங்க. அவனை கார்டியக் ரெசிஸ்டேஷன் பண்ணி ஐசியூக்கு எங்க பேர்ல எடுத்துட்டு போய் அவனோட பிறந்த நாள் அன்று அந்த செகண்ட் டே அவன் வந்து உயிர் பிழைத்தான். அண்ட் இது அவனோட பர்த்டேவை நாங்க ஐசியூல கொண்டாடின நேரம் இது. அண்ட் அன்று வந்து ஒரு யோசனை வந்தது, we are not going to let one single poor child with type 1 diabetes die or suffer for want of best treatment to get the best insulins or best technology. So அன்னைக்கு அர்ஜுனின் மறுபிறப்பு எங்கள் இதயங்கள் சேரிட்டபிள் ட்ரஸ்டின் பிறப்பு. ஸோ இன்னைக்கு நம்ம வந்து அன்பார்ச்சுனேட்லி மெடிசனும் சரி எந்த துறையும் சரி, இதனால் எனக்கு என்ன வரும், பணத்தால் என்ன வரும், எனக்கு இதை போட்டா எனக்கு என்ன நம்ம கேட்டுட்டு இருக்கோம். பட் இந்த 6 or 7 years டைப் 1 டயபிட்டிஸ் ஒர்க் நாங்க பண்ணி பணத்தால் வாங்க முடியாது நிறைய பார்த்துட்டோம். அண்ட் இது என்னுடைய ஆர்டர், இது தாயின் பாசம்னு சொல்வேன். சலிக்காமல் சமைக்கும் கணவன் பணத்தால் வாங்க முடியாது. என் ஒய்ஃப் அதை வேற வழி இல்லாம அக்ரி பண்ணியே ஆகணும். நச்சு பண்ணாத மனைவி, பண்பான குழந்தைகள், பட் ரொம்ப முக்கியம் நம்ம பேஷண்ட்ஸோட பிளெஸ்ஸிங்ஸ். அதாவது டாக்டர் உங்க குடும்பம் நன்றாக இருக்க வேண்டும் என்ற நம்ம பேஷண்ட் பிளெஸ்ஸிங்ஸ்க்கு விலை மதிப்பே கிடையாது. எனக்கு இந்த அர்ஜுன்கிற பையன் என்ன பண்றான்னா, இப்ப அவனை சப்போர்ட் பண்ணிட்டு இருக்கோம் நாங்க, அவனோட இன்சூரன்ஸ் எஜுகேஷன் எல்லாத்துக்குமே. அண்ட் எவ்ரி பர்த்டே he sends this to my daughter. அவனோட ஒவ்வொரு பிறந்த நாளும் சிறுக சிறுக சேமித்த காசில் இதை என்னோட டாக்டருக்கு அனுப்புறான், just to thank for the support that we have done. இன்றும் நம்ம வந்து we allow patients to die with kidney failure at the age of 20 and 25 with type 1 diabetes. இது சத்யபிரகாஷின் குடும்பம். இது இந்த பையன் வந்து ஒரு வருடம் முன்னாடி என் கையை பிடித்து கொண்டு இறந்து போனான். எனக்கு பார்க்க வேண்டிய நேரத்துல அவனுக்கு சரியான சப்போர்ட் கிடையாது. ஒரு இன்சுலின் சிரிஞ்ச 30 டைம் யூஸ் பண்ணுவான் அந்த பையன். மல்டிபிள் ஆப்சஸ் வரும், கிட்னி ஃபெயிலியர். நாங்க அவங்களை பார்க்கும்போது லாஸ்ட் 1 yearல தான் எங்க கிட்ட வந்தான். We supported him as much as possible, but he died because of advanced kidney failure, unable to support major ICU admissions. And அன்று கையை பிடித்து அவன் இறக்கும் பொழுது என்கிட்ட சொன்னது ஒண்ணுதான், என்ன சத்யபிரகாஷ் சொல்லணும் சார், முதல்ல நன்றி அப்படின்னா சப்போர்ட்க்கு. 2வது என்னோட குழந்தைக்கு 4 வயசு, அது கொஞ்சம் காலேஜ் வரைக்கும் பார்த்துக்கோங்கன்னா. 3வது ஒண்ணு சொன்னான், அது நம்ம மருத்துவர்களுக்கு சாட்டை அடி. சந்திரனுக்கு ராக்கெட் அனுப்புற தேசத்துல ஒரு சர்க்கரை நோய்க்கு பார்க்க முடியாம என்ன வீட்டுக்கு இறப்பதற்கு அனுப்புறீங்க டாக்டர், இன்னும் ஒரு சத்யபிரகாஷ் வரக்கூடாது. அது அன்று அவன் கையை பிடித்து சொன்னதான் எங்களோட கனவு. We are not going to allow anyone to suffer with type 1 diabetes. ஸோ இது மாதிரி பல கதைகள் டாக்டர்ஸ் மத்தியில ஒரு ஆடிட் நம்மளே ஒரு மிரர்ல வச்சு பார்க்கணும்னா நான் இதுதான் பாக்குறேன். மருத்துவர்கள் மத்தியிலேயே டைப் 1 டயபிட்டிஸ் பத்தி ஒரு நெகட்டிவ் மைண்ட் செட் இருக்கு. அதாவது இது ஒன்றும் தேராது, ஐசியூல செத்து போயிடுவான் அவன் பையன், இது மாதிரி வார்த்தைகள். இட்ஸ் அ புவர் கசன் ஆஃப் டைப் 1 டயபிட்டிஸ். ஒரு டைப் 1 டயபிட்டிஸ் குழந்தைய பார்க்கணும்னா 3/4 மணி நேரம் ஆகும். ஃபேமிலி கவுன்சில் பண்ணும், அவங்க கையில பணம் இல்லைன்னா சப்போர்ட் பண்ணுவோம். அந்த நேரத்துல 10 பேஷண்ட் நம்ம பார்த்துட்டு போயிடலாம்னு நினைப்போம். there's no quality time. ஃப்ரிட்ஜ் இல்லாமல் பல குழந்தைகள் டயபெட்டிக் கீட்டோசிஸ்ல வந்திருக்கு. நிறைய டைம் நம்ம ஃப்ரிட்ஜ் இருக்கான்னு கூட கேட்கறது இல்லை வீட்டுல. இந்த வயல்ல ஸ்டோர் பண்ற இன்சுலின்லாம் இந்த 30 நாள் வச்சுக்கலாம், 28 நாள் வச்சுக்கலாங்கிறதுலாம் என்ன பொறுத்த வரைக்கும் ரபிஷ். அது எல்லாமே பொட்டன்ஷியல் லூஸ் ஆயிடுது. மோஸ்ட் ஆஃப் அவர் டிகே அட்மிஷன்ஸ் were because there was no fridge at home and in the children were storing in vials. காஸ்ட்லி இன்சுலின்ஸ், நம்ம இந்த அனலாக் இன்சுலின்லாம் வந்திருக்கு. 7,000 ரூபாய் 8,000 ரூபாய்க்கு ஒரு மாசத்துக்கு எழுதிட்டு இருக்கோம். பேஷண்டோட வருமானம் என்னன்னு நம்ம கேட்க மாட்டோம். எனக்கு அவன் ஒரு கூலி வேலை செய்யற 6,000 ரூபாய் இருக்கிறவன் அவன் 7,000 ரூபாய்க்கு எப்படி இன்சுலின் வாங்க முடியும்? பல பேர் வந்து 10 வட்டிக்கு வாங்கி கொடுத்துட்டு இருக்காங்க. புவர் அவேர்னஸ் ஆஃப் இன்சுலின் பம்ப் தெரப்பி. நிறைய மருத்துவர்களுக்கு இன்சுலின் பம்ப் தெரப்பின்னா என்னன்னு சரியா தெரியாது. அதனால இந்த பம்ப் எல்லாம் போடுறது வேஸ்ட், இது வேஸ்ட் ஆஃப் டைம், இதெல்லாம் சரிப்பட்டு வரலன்னு டாக்டர்ஸ் சொல்ற நிலைமை இருக்கு. அண்ட் பெண்கள் வித் டைப் 1 டயபிட்டிஸ் இஸ் வெரி க்ளோஸ் டு அவர் ஹார்ட். ஒரு ஆணுக்கு இன்னைக்கு ஒரு கிராமத்துல எய்ட்ஸ் பாசிட்டிவா இருந்தா கல்யாணம் பண்ணி வைக்கலாம். ஆனாக்கு ஒரு பெண்ணுக்கு இன்சுலின் போடுறது இருந்தா கல்யாணம் பண்ணது ரொம்ப ரொம்ப கஷ்டமா இருக்கு. அண்ட் அது நம்ம என்ன சப்போர்ட் பண்ண முடியுமோ அதை எல்லாமே சப்போர்ட் பண்ணும். ஸோ இது ஒன் ஆஃப் த பேஷண்ட்ஸ் வேர் த டாக்டர் ஹட் டோல்ட் இன்சுலின் பம்ப் தெரப்பி பத்தி போய் கேட்டிருக்காங்க அந்த பேஷண்ட். இது இந்தியன் வெதருக்கு இட் இஸ் நாட் சூட்டட் அப்படின்னு. இது 3 months HbA1c 16% இந்த பொண்ணுக்கு. Within 3 months of insulin pump therapy, this is the tracing that we got with the EA1C of 4.8%. Glucose is absolutely under control. So what is the pain of a poor family? வருமானம் 8,000, 2,500 3,000 ரூபாய் அனலாக் இன்சுலின் கொடுக்கணும்னா கன்சியூமபிள்ஸ் நீங்க ஆட் பண்ணீங்கன்னா ஈஸியா 4,000 வரும். ஒரு டிகே அட்மிஷன் a very good corporate hospital is 80,000 to 1 lakh, but there's no price that you can put for a cost of a child's life. And என்னுடைய மகளின் உயிரும் ஒரு இன்னொரு பெற்றோரின் மகளின் உயிரும் எந்த விதத்திலும் வித்தியாசம் இல்லை. இட் கேரிஸ் த சேம் வே. ஸோ இது அப்துல் கலாம் ஐயாவின் சாட்டை அடி அப்படின்னு சொல்வேன். இது மருத்துவர்களுக்கு நான் எடுத்துக்கிறேன், பட் யாருக்கு வேணா எடுத்துக்கலாம். நம்ம சிங்கப்பூர் ஏர்போர்ட்டை விட்டு வெளில போனோம்னா அக்மார்க் சிட்டிசனா நடந்துப்போம். நம்ம அங்க போய் சிகரெட்டை தூக்கி போட மாட்டோம், எனக்கு 2 போடு போட்டு உள்ள தள்ளுவோம். ரம்ஜான் போது துபாயில நம்ம சாப்பிட மாட்டோம். ஆனாக்க இங்க நம்ம என்ன பண்ணுவோம் அப்படின்னா, நான் என்னங்க பண்ணுறது, நம்மளால என்ன பண்ண முடியும், இது அரசாங்கம் பண்ணும், அவங்க பண்ணும், இவங்க பண்ணுங்கிறாங்க. பட் நீங்களோ நாங்களோ இல்லை, டெஃபினெட்லி நாட் மீ அண்ட் யூ. ஸோ இந்தியா மாறணும் என்றால் நம்ம என்ன நினைக்கிறோம்னா, வேற எவனோ மாத்துவான்னு நினைக்கிறோம், இல்லைன்னா அமெரிக்கா லண்டனுக்கு ஓடி போய் நம்ம அங்க சேவகம் பண்ணிட்டு இருக்கோம். பட் ஒன்லி பர்சன் ஹூ கேன் மேக் அ சேஞ்ச் இஸ் மீ அண்ட் யூ அப்படிங்கிறாரு அப்துல் கலாம் ஐயா. ஸோ we are not here to change the world. இந்த நாடு நம்மளால மாற்ற முடியும்னு நமக்கு தெரியல, பட் என்ன மாற்றம் நாம் உண்டு பண்ணணும் என்று நினைக்கிறோமோ அந்த மாற்றத்தை நாம் ஆரம்பிக்க வேண்டும். அதுதான் இங்க பாயிண்ட். ஸோ our passion, our dream to make the impossible possible is no single poor child with type 1 diabetes, especially from poor socioeconomic status, should die or suffer from comorbidities like kidney failure for want of the best insulin, moral or financial support. We want to make them responsible adults in the future so that they can give back to the society what they received. And பெண்களுக்கு கல்வியும் திருமணம் எம்ப்ளாய்மெண்ட் எல்லாமே நம்ம பண்ண போறோம். இதுதான் நாங்க ஆரம்பிச்சோம். ஸோ இன்சுலின் பம்ப் பத்தி ஒரு பிரீஃப் இது. The concept is very simple, the basal and bolus. And இதுதான் மல்டி MDA கொடுக்குறோம். I believe that anyone with type 1 insulin pump therapy is the first choice. இதை விட physiologically superba யாருக்கும் தர முடியாது. So the pump uses the basal bolus delivery. In the basal rate every half an hour நம்ம adjust பண்ணிக்கலாம். And latest pumps 0.025 units per hour levelக்கு நம்ம adjust பண்ணிக்கலாம். Bolus, the child can eat anything they want suddenly. So all they have to do is to give a bolus. இப்போ எங்க குழந்தைங்களாம் பம்ப்ல இருக்கிற குழந்தைங்களாம் they eat everything and they give a bolus. They give at least 6 to 7 bolus a day. The cost can be prohibitive. So 2.2 lakhs ல இருந்து 5.2 lakhs வரைக்கும் இருக்கு different models of pump. And ஒரு நிமிஷம் பேட்டரி கொஞ்சம் இதாகுது. And AAA battery தான் 300 units of insulin per day, 4 days once மாத்தினா போதும். So suddenly 12 injections 4 times a day becomes 1 prick every 4th day. So என்ன நாங்க பண்ணோம்னா, தனி மனிதனா எதுவும் பண்ண முடியாது. நான் மிஞ்சி போனா ஒரு பேஷண்ட்க்கு 5,000 ரூபாய் தரலாம், ஃபீஸ் வாங்காம இருக்கலாம். But if we want to do some really big work, we need a trust where we can get some funds to do a lot of good things. So எங்க கோயம்புத்தூர் model is based on இதயங்கள் charitable trust. இப்போ 4th year running இது. It's a 12A, 80G and a CSR approved trust. And we've got to thank Dr. Nalaji Palaniswamy, எங்க chairman. அவரை விட ஒரு humanitarian பார்க்க முடியாது. ஒரு corporate hospital உட்காந்துட்டு அந்த மாதிரி ஒரு consultant, he allows me to do trust work. We don't receive any fees for our trust patients. And I'm doling out around 1 lakh worth of insulin from my office, undercutting all the other pharmacies. So chairman is a big supporter of the work we do. ஒரு 10 குழந்தைங்களோட ஒரு 4 வருடம் முன்னாடி ஆரம்பிச்சோம். And we thought we'd give the best insulin in pen-fill cartridges, needles, glucose strips, education for girls with type 1 diabetes, and insulin pump for indicated patients. So இப்போ என்ன பண்றோம்னா, இது வரைக்கும் 200 children now on our program throughout the state of Tamil Nadu, Kerala and Karnataka. தமிழ்நாடு ஹெவியா கான்சென்ட்ரேட் பண்றோம். ஸோ கோயம்புத்தூர், ஈரோடு, திருப்பூர், திருச்சி, நாமக்கல், சேலம், எடப்பாடி, மாயவரம், திருநெல்வேலி, இப்ப சென்னை, வந்தவாசி எல்லாத்தையும் கவர் பண்றோம். 100 still on the waiting list. நிறைய பேர் எங்களுக்கு வெயிட்டிங் லிஸ்ட்ல இருக்காங்க. ஸ்டார் ஹெல்த் இன்சூரன்ஸ் வழியா for the first time we have put 2 crore worth of ஸ்டார் ஹெல்த் கவர். கிட்டத்தட்ட ஒரு 80 குழந்தைங்களுக்கு 2 lakhs per annum. இன்னைக்கு டைப் 1 டயபிட்டிஸ் இருந்துச்சுன்னா ஹெல்த் இன்சூரன்ஸ் கிடையாது. ஸோ ஸ்டார் ஹெல்த் மெடிக்கல் டைரக்டர் கூட பேசி they have waived off all pre-existing conditions for our children so that they have a cashless card. All poor children can get admitted. Last year மட்டும் ஒரு 15 children's lives இது வழியா சேவ் பண்ணிருக்கோம். We have given around 60 lakhs worth of best insulins. We don't stop insulins at all. And we are talking about analog insulins, the best analog insulins in pen-filled cartridges at their doorstep. If 19 portrican now, we've got 100 children on the insulin pumps. It's one of the Asia's largest program for insulin pump. And எங்களோட average HbA1c வந்து இப்ப நீங்க பாத்தீங்கன்னா எங்க பம்ப் குழந்தைங்களுக்கு ஒரு 5.5 to 7 குள்ளார இருக்கு. And I'm talking about rural children who are extremely poor with illiterate parents. கிட்டத்தட்ட ஒரு 100 fridges support பண்ணிருக்கோம். And we are supporting girls with type 1 diabetes for college education. And some of the evidence, பேசுறதெல்லாம் ரொம்ப நல்லா இருக்கு. What is the evidence? So this is an article in IJEM, Breaking Socioeconomic Barriers in Pump Technologies. இது வந்து ஒரு first 16 pilot பண்ணுனாங்க, 16 children, and this is what we saw. அதாவது baseline HbA1c from 11.4 within 3 months of pump therapy comes down to 8%, and it's sustained at around 8 to 8.2% at the end of 1 year with a huge reduction. We are talking about 90% reduction in DKA or hospitalizations for hypoglycemia. And we have added on the next 76 patients. And again, we are seeing a big reduction, 12.8 HbA1c at baseline, pre-pump 10.6, and again 8.2 to 8.6. And we know that 1% HbA1c reduction in type 2 diabetes is equal to around 20 to 25% reduction in kidney failure. So if you're talking about a 3% reduction that we can sustain over a period of time, then it's practically reducing kidney failure in a big way and major hospital admissions. And DKA episodes, for people who have completed 1 year of pump therapy, pre-pump 13 irundadi per 2 episodes vandiruchu, and 282 hypos irundadi 76 vandirukku. So we are working in terms of cost economic modeling, and we are seeing that pump therapy is actually cheap in the long run in preventing morbidity and mortality. So எப்படி இத பண்ண முடியுதுன்னா, இது நிறைய பேர்கிட்ட போய் கெஞ்சணும், காலில் விழுவணும், பிச்சை எடுக்க வேண்டும், but it's a very rewarding begging. So if project Kadir அப்படின்னு சொல்லிட்டு, it's a $95,000 US grant we have got from Rotary International Rotary Club of Coimbatore Central with our chairman, and if over 40 children, it is helping around 15 children on pumps and 25 children on insulins. The Coranda Ramya Bharati brought with cerebral edema with glucose of 800 and from a very, very poor socioeconomic strata. And she's doing extremely well on a pump with a HbA1c of 6.2% recently. And the again, sugars of more than 600, now HbA1c of around 6% on pump from Tirunelveli. So we are managing people with pumps far away. Maavaram, Tirunelveli, Vandavasi, Dindivanam, manage பண்ணிட்டு. With Vasantha Sri, again, she lost a year because of Pseudomonas infection due to undiagnosed type 1 diabetes and DKA. And பெண்களுக்கு heavier support பண்ணிட்டு இருக்கோம். இதெல்லாம் எங்களுடைய குழந்தைகள் all doing extremely well on insulin pump therapy from very poor socioeconomic status. So pump cost is somewhere around 1.5 lakhs and consumables cost around 9,000 to 10,000 rupees per month. So it's a lot of money, but we think it's worth the effort because there's some good evidence for pump therapy in terms of long-term reduction risks of not only microvascular complications and DKA or hypoglycemia, but reduction fatal CVD and all-cause mortality. So insulin pump therapy without prejudice in motivated rural underprivileged children leads to significant reductions in A1C, hospitalizations for DKA and hypoglycemia. நம்ம முடியாதுன்னே பழக்கப்பட்ட தேசமா இருக்கும். நம்ம எது இருந்தாலும் நம்மளால முடியாதுன்னு நினைக்கிறோம். எஸ் வி கேன் சொல்ல ஆரம்பிக்கிறோம். அதான் என்னோட பாயிண்ட் இங்க. இப்ப இது வந்து அரௌண்ட் 50 children on insulin pumps, and we have a fantastic 4-member team. So 2 pump starts per week பண்றோம். எல்லா குழந்தைகளுக்கும் we put a AGP sensor and we give a reader to them at their home. So இவங்க திருநெல்வேலி, மாயவரம், கும்பகோணம் எங்க இருந்தாலும் எங்களுக்கு ஜஸ்ட் ரீடர் அவங்க கையில ஸ்வைப் பண்ணிட்டு எங்களுக்கு 78 times a day எங்களுக்கு போட்டோ எடுத்து அனுப்பிச்சிட்டே இருப்பாங்க. If they don't have a WhatsApp phone, we give them a WhatsApp phone so that within 3 days we are able to get the basal rates right now because of the AGP, and 2 weeks போட்டு எங்களுக்கு அவங்க அனுப்பிச்சிடணும். And every 3 months every kid gets a free AGP. so that we keep a track on their glucoses and ensure that the HbA1c is well controlled. And 3 months for a time என்ன வந்து பார்த்து HbA1c இல்லாமல் நாங்கள் extend பண்ணறது கிடையாது அந்த consumables. So all of them have to come and see me. We waive off all the fees for all the patients. They don't get blood tests through corporate hospitals. We use Shanti Social Service, which is a very cheap but very high quality center for blood investigation. So in the model la pathina avங்களுக்கு எந்த செலவும் கிடையாது, அவங்க ஃபீஸும் கிடையாது. We are giving a really high end technology that is life changing for them, and all they have to do is to come and see us every 3 months, which they happily do. So challenges கிடையாதா, அதாவது இந்த 4 வருடம் எங்களுக்கு தூக்கம் கிடையாது, கனவு தூங்கி எழுந்திருச்சு படுக்கும் பொழுது how are we going to get this better? எனக்கு இப்ப எங்களுக்கு இன்னொரு 200 குழந்தைங்க வெயிட்டிங் லிஸ்ட்ல இருக்கு. So rural underprivileged and technology, it's a gamble. ஒரு குழந்தைக்கு ஒரு பம்ப் சரியா வேலை செய்யாம டிகே மாயிரம் தாண்டி போயிடுச்சுன்னா கூண்டுல ஏத்துறதுக்கான வாய்ப்பு இருக்கு. So we have to be very mindful of using these kind of high-end technologies in remote rural areas. But we are very surprised. அதாவது எங்க அர்பன் பணக்கார குழந்தைய விட எங்களுடைய ஏழை குழந்தை சூப்பர்வா பண்ணுது இன்ஸ்டன்ட் பம்ப். அதுக்கு பேசல் ரேட்னா என்னன்னு தெரியும், கார்போஹைட்ரேட் கவுண்டிங்னா என்னன்னு தெரியும். அங்கிள் பேசல் கொஞ்சம் டெம்பரரி பேஸ்லாம் மாத்தினா அடுத்த 1 மணி நேரத்துக்கு விளையாடுறதுனால இருக்கும். ஸோ which is really surprised how fast they catch it. ஒருத்தர் பண்ண முடியாது. It's a big team effort. We've got 2 Medtronic guys, one an absolutely fantastic pump expert, 24/7 work இது. Around 100 children to data night முழுக்க வந்துட்டே இருக்கும். We need to keep a very close eye on that. We got an educator from Medtronic as well. Shobana எங்களோட இதயங்கள் ட்ரஸ்ட் manages a very senior diabetes nurse, Gurumurthy Nanu. So it's a 5-member team who are 24/7 connected all the time. Financially, it's a huge thing. On an average, we are spending 7 to 10 lakhs per month to support these children, and add ite irukku. So 10 lakhs per month is not easy. It's so difficult. But we've got to really thank Rotary clubs, Lions Club, great philanthropists and corporates who are helpful. In the COVID netla romba kavalaippattum, but in the COVID netla the maximum donate pannanga. Great people. So we are just so thankful to them. And long term sustainable, அதுவும் ஒரு பெரிய question. நாங்க அன்றாடம் இந்தியால நான் தான் சொல்லுவேன், பிளான் பண்ணா வேலையே நடக்காது, பண்ணிட்டு தான் பிளான் பண்ணுவீங்க. எனக்கு இல்லைன்னா ஐயோ இதை பண்ண முடியுமான்னு நினைச்சிட்டு நம்ம ஓரமா உட்காந்துருப்போம். But we really believe now that after finishing 3 years and doing work worth 3 crores, I think we believe that we'll be able to do it. So this is the Coimbatore model. I would encourage all of you to try and think about this model. என்ன பொறுத்தவரை ஒவ்வொரு டாக்டரும் ஒரு ட்ரஸ்ட் வச்சிருக்கணும் நல்ல காரியத்துக்காக. So we can easily get 12A, 80G and CSR approval. நமக்கு இருக்கிற பவர் வேற யாருக்குமே கிடையாதுங்க. நமக்கு இருக்கிற பேஷண்ட் லோடு பணக்காரங்க பெரிய பெரிய கார்பரேட்ஸ் எல்லாம் நம்ம கையை காட்டினா பண்ணுவாங்க கண்டிப்பா, if they know that the cause is good. So other people's money is very important. Auditing every single rupee counts. So we don't take any money or cash. Every single rupee is electronic transaction, and it's audited by one of the top auditors in Coimbatore. CSR grants ipo engalukku nariya vara aarambichirukku. We rigorously screen socioeconomic status. One of our team members goes to their houses to confirm that this is what they are. 2 pump starts a week, interconnecting patients. Ipo engaloda kulandinga ella andha area leaders. நீங்க திருச்சியில ஒரு பேஷண்ட் வந்தா ஐ கேன் கனெக்ட் அ பேஷண்ட் ஹூ இஸ் a pump authority அங்க. இப்ப தால்மியாபுரத்துல இருந்து ஒரு குழந்தைக்கு நேத்திக்கு போட்டிருக்கோம். So and 90 children on this rural program. So I just want to finish by saying that there's a huge burden of type 1 diabetes increasing by about 3 to 5% per annum. I think every doctor should understand the pain of children and their families, especially from rural underprivileged areas. At least இன்சுலின் எழுதுறதுக்கு முன்னாடி நீ என்ன சம்பாதிக்கிற உன்னால முடியுமாங்கிறதையா நம்ம யோசிக்கணும். Insulin pump therapy in selected patients is a godsend for type 1 diabetes, especially in deserving children. I think doctors, we need to think more and do more. இந்த 4வது வீல நம்ம பார்த்துட்டே இருக்கணும். நம்ம வேலை, நம்ம குடும்பம், நம்ம காரு, நம்ம வீடுன்னு பார்க்கறத தாண்டி I'm sure a lot of you are doing great work. And the 4th wheel of community நம்ம யோசிச்சுட்டே இருக்கணும். Private, NGO, industry, government partnership is the need of the hour, and there are a lot of people willing to do that. I just want to give this last slide where teamwork is very important. So அதான் சொல்றேனே, நான் இதை பண்ண முடியும்னா 35% தான் என்னால. எஸ்பிபி அருமையா சொன்னார் அந்த ஒரு அவார்ட் செரமனில, 35% தான் என்னுடைய குரல், 65% is what other people do. So எங்க டீம், எங்க ட்ரஸ்ட் டீம், எங்களோட மெட்ரானிக் டீம், மெட்ரானிக் கம்பெனி வந்து they waived off a lot of money for us. இதெல்லாம் இல்லைன்னா நம்மளால பண்ண முடியாது. But we first want to thank all our children and families for giving us an opportunity to be of help. அந்த வாய்ப்பை எங்களுக்கு கொடுக்குறாங்க. They're all more than family to us. Everyone is a daughter or son to us. And KMC chairman, we are just greatly indebted for him to allow us to do this work. diabetes team, trust team, Sabri and Vinod from Medtronic, Dr. Vinay and Professor Wahat Kovan from Medtronic, who give a lot of input on how to do these kind of technologies in rural areas. All the Rotaries, Lions, Rotary International, Medtronic India, and all our donors and well-wishers. And in the photo, just to சொல்லிட்டு நிறுத்திட்டேன் நானு. இந்த பெரியவர் ராமூர்த்தின்னு சொல்லிட்டு ஹொசூர்ல இருக்காரு. இவர் திடீர்னு ஒரு நாள் கூப்பிட்டாரு, டாக்டர் உங்க ட்ரஸ்ட்டை பத்தி நான் கேட்டிருக்கேன், எனக்கு 95 வயது ஆகிறது, இல்லைன்னா நான் கோயம்புத்தூர் வந்திருப்பேன், நீங்க ஒரு சண்டே மட்டும் இங்க வர முடியுமா அப்படின்னாரு. ஒரு 95 பெரியவர் நம்மள பிளஸ் பண்ணறதுக்கு கூப்பிடுறாரு அப்படின்னு நாங்க கிளம்பி ஹொசூருக்கு போனோம். அண்ட் போகும்பொழுது பேசணும், அவன் ஏதோ 5000 10,000 தருவாரு, அட்லீஸ்ட் அந்த பெரியவர் அந்த கொடுக்குற ஒவ்வொரு ரூபாயும் ஒரு குழந்தைக்கு போற மாதிரி இருக்கட்டும் அப்படின்னு போய் அவர் கூட ஒரு 10 நிமிஷம் கேட்டுட்டு செக் புக் எடுத்துட்டு 4 லட்சம் எழுதினாரு செக்ல. ஒரு ரிட்டையர்ட் பென்ஷனர், 95-year-old பென்ஷனர், who's got an extended family, 3 பசங்க, பேர பசங்க எல்லாம் இருக்காங்க. he gave 4 lakhs. அண்ட் தொண்டையை அடைத்தது, கண்ணுல இருந்து தண்ணீர் வந்தது. கதவை சாத்தத்துக்கு முன்னாடி டாக்டர் ஒரே ஒரு ரிக்வெஸ்ட் அப்படின்னாரு. என்ன சார் அப்படின்னா, ஜாதி மத பேதம் பார்க்காமல் எல்லா குழந்தைகளுக்கும் மாறு பண்ணுங்க டாக்டர் அப்படின்னு. அண்ட் அவரோட வாய் முகூர்த்தம் அந்த வாரம், அடுத்த வாரம் வந்து ஸ்டேசி நாமக்கல்ல இருந்து ஸ்டெய்னி, அண்ட் பூர்ணிதா ஃப்ரம் கோயம்புத்தூர், அண்ட் ஆயிஷா ஃப்ரம் ஈரோடு, ஹிந்து, முஸ்லிம் அண்ட் கிறிஸ்டின் 3 குழந்தைகளுக்கு அவரோட பணத்துல இருந்து அந்த பம்பை கொடுத்தோம். ஸோ தேங்க்யூ வெரி மச் ஃபார் த அட்டென்ஷன். எனி டைப் 1 டயபிட்டிஸ் புவர் சில்ட்ரன் இருந்தா ப்ளீஸ் எங்களுக்கு சொல்லுங்க. இட் இஸ் நாட் அபவுட் யார் வழியா பண்ணது அப்படின்ல, நீங்க பண்ணுங்க, நாங்க ஹெல்ப் பண்றோம். அண்ட் பம்ப் தெரப்பி இண்டிகேட்டட் பேஷன்ஸ் இருந்துச்சுன்னா கண்டிப்பா எங்களுக்கு சொல்லுங்க. end to end will support. And Kauvery madam, thank you very much for this opportunity.
Sir, Krishan sir, ரொம்ப அருமையான தெளிவான ஒரு பதிவு. Hats off to you sir, and may God bless you for this phenomenal work. அநேகமா எல்லாத்துக்கும் இருக்கக்கூடிய ஒரே கொஸ்டின் வந்து, சார் இப்போ எங்க பேஷண்ட்ஸ் உங்ககிட்ட எப்ப அனுப்புறது அப்படிங்கிறது தான் அடுத்த கொஸ்டின். எப்படி ரீச் பண்ணணும் உங்களை? how do we send our patients if they, and one other question I have is, do all type 1 children should we start on insulin pump or choose பண்ணி அனுப்பணுமா உங்ககிட்ட?
அதாவது if you look at the indications madam, very brittle diabetes in spite of being on multiple daily insulin injections for 6 months, unable to get a HbA1c less than say 8.5 but at least less than 9 குள்ளார வரல அப்படின்னா ரொம்ப கஷ்டம் மேடம். I think 9க்கு மேல இருந்துச்சுன்னா கண்டிப்பா we are exposing them into huge amount of kidney failure. Pregnancy நாங்க type 1 pump இல்லாம நாங்க பண்ணறதே கிடையாது, because I think it works beautifully well, and insulin increased dose is around 150 to 200%. So all our pregnant women are on pumps. Renal failure dialysis pump is unbeatable. So I think, and recurrent hypoglycemia or hypoglycemic unawareness, சில குழந்தைங்களுக்கு பார்த்தா ஒரு யூனிட் கொடுத்தா சுகர் 20 ன்னு வந்து கோமாக்கு போயிடும், ஒரு யூனிட் ரெடியூஸ் பண்ணா 400 ன்னு வரும். So ரொம்ப difficult to control brittle diabetes. So எங்க 100 patients they are on absolute indications on the pump. எல்லாமே MDA try பண்ணி with everything they have tried and unable to reach that. So those are the main indications. But given a choice, I think pump therapy, even for well control, I would say it's a great idea, but financial constraints பார்க்கும்போது இந்த indications போகணும்.
So all your pump children, are they doing 4 times 3 times sugar checks per day?
அது இல்லைன்னா நாங்க திருப்பி எக்ஸ்டெண்ட் பண்ண மாட்டோம் மேடம் கன்சியூமபிள்ஸ். பட் 4 times வந்து சில சமயம் கஷ்டப்படுறாங்க, சில டாக்டர்ஸ் 7 8ங்கறாங்க, அது ரொம்ப கஷ்டம். we say at the minimum 2 times a day சொல்றோம். So they have to come with their memory sticks, glucometers when they come to see us, and அந்த memory நாங்க கேர்ஃபுல்லா பார்ப்போம். So 2 times a day பண்ணோம். weekly once வந்து என்கிட்டயோ இல்ல மெட்ரானிக் எக்ஸ்பர்ட்க்கோ ஃபோன் பண்ணோம், and 3 months ஒரு டைம் நேர்ல வந்து பார்க்கணும். and HbA1c 7 குள்ளார வரலனா ஏன் வரல அப்படிங்கறத சொல்லணும். So it's a very tight system, madam.
I request the other panelists to add on some valuable points to Dr. Krishan Swaminathan. Masi sir, Akila madam, Harish sir.
Dr. Krishan Swaminathan, in his usual way, he has made a very good and an impressive presentation to all our viewers and listeners of this program. Definitely, it is going to be a key message for all the doctors who have attended today's program to at least achieve and maintain the patient's glycemic status nicely. In case if they fail to achieve, naturally they will refer their patients to Dr. Krishan Swaminathan.
Thank you, sir. Thank you.
Thank you, sir. Thank you. Sir,
Madam,
Krishan sir,
just to-
உங்களோட இதயங்கள் மாதிரி Kauvery Hospitalல we also run a social welfare club for type 1 children. It's called Sigaram. நாங்களும் ஏதோ எங்களால முடிஞ்ச அளவுக்கு ஒரு இது பண்ணி ஒரு 60 to 70 children are there in Sigaram. We educate them. நாங்க இன்சுலின் பம்ப் எல்லாம் கொடுக்க முடியறது இல்ல. Maybe we will refer all those children to you in future. So we have a nice video or by a type 1 boy அது அடுத்தது போட போறோம். So friends, be all linked in to us. And before going to that video, I request our executive director, HOD Pediatrics, Dr. Sengutuvan sir, to give us closing remarks.
Madam, ஒரே ஒரு பாயிண்ட் மட்டும் சொல்லிடலாமா? Just one point. First of all, வந்து any help is godly, madam. இதுதாங்கிறது கிடையாது. Whatever you do is great for our patients. And if anyone wants to contact regarding poor patients, just Dr. Krishnan Swaminathan, இதயங்கள் charitable trust னு கூகுள் பண்ணா அதுல எங்களோட phone numbers, email ID எல்லாமே இருக்கு. So feel free to call us, especially anyone needing pump therapy, let us know.
கட்டாயம் sir. Thank you sir.
And thank you, Dr. Gauri. Thank you. And first of all, I am very proud today, not only today, for this past few years, as a director of Kauvery Hospital. I got a very good team to take care of diabetic children in this region. It has been anchored by Dr. Gauri. He's a full-time diabetologist. And it was well supported by our team of pediatricians, Dr. Meghanathan and Vignesh and their with their colleagues. And we have got a good dietitian with a counselor. Along with that, we have got a club for the diabetic children. That's called Sigaram. In the Sigaram Ulema, we do a lot of services and we started doing it. But probably Krishnan Swaminathan இதை பார்க்கும்போது நம்ம ஒண்ணுமே இல்லை, ஒரு எறும்பு மாதிரி இருக்கிறோம்னு நினைக்கிறேன். எறும்பளவு கூட இல்லை, அணுவளவு.
We still have to grow, sir. நம்ம எறும்பு கிடையாது. We have to grow.
Yeah, but Krishnan Swaminathan, definitely you are motivating us to do something good, and we've been looking for. Probably our association should go ahead and in a long way. We'll meet in a good other occasions to share our knowledges and all those things.
Sure.
And definitely எங்களோட கிளப்ல இருந்து இப்ப அடுத்த ஒரு வீடியோ ஒரு just another 2 minutesல will have our video, just our club member, how he is grown and how he is performing. Definitely. Before that, yes, I thank Dr. Akila Ayavu for her wonderful presentation regarding the obesity in childhood. Probably a balanced diet with adequate, proper carbohydrate, protein, and fat with simple exercise. It's a best way to prevent the obesity. That's what I understand from her. And thank you, Dr. Harish Kumar. And definitely, it's a wonderful. And once again, you proved that basic is essential. That is to prevent the error. To take care of just check the site of the insulin and the syringes, checking the syringes and rotating the cartridges. All the basics things is more important in preventing the error of the insulin therapy. And as usual, Dr. Shanmugavelu is a young hero. ஆரம்பிச்சானா பட ஒரு வாட்டில் அடிச்சாரு.
தீபாவளி பட்டாசு மாதிரி.
Diwali, the real Diwali scenario, I enjoy that. And definitely he started with auto antibody to diagnose on unmanifested type 1 diabetes. From here, he went on to oral anti-hypoglycemic drugs. From there, he went on to gene therapy. From there, he went on to transplant. So many things. Excellent hero Shanmugavelu. And once again, Krishnan Swaminathan, definitely எங்களை ரொம்ப சிறுமையா நினைக்க வச்சிட்டீங்க நீங்க. And definitely you are doing a wonderful job. And கோயம்புத்தூர் மாடல் ஆஃப் இன்சுலின் பம்ப். நான் டாக்டர்கிட்ட கேட்டேன், இது என்ன டாக்டர் கோயம்புத்தூர் மாடல்னு ஒன்று புதுசா போட்டிருக்கீங்க, என்னது இது அப்படின்னு கேட்டேன். இல்ல சுவாமிநாதன் insisted on that அப்படின்னாங்க. Now I realize the importance of it. And definitely thank you all for a wonderful presentation today. And thank you my team, especially Dr. Meghanathan and Vignesh. They are always in support of our pediatric team, and not only in this occasion ever. And as usual, they have done a wonderful job for the past 1 week, 10 days. And once again, thank you all. And Dr. Kauvery, definitely you are doing a lot of good job. We have to continue to do that. And probably these legends are probably with their motivation, you are doing a lot of good work, I believe. Good. Thank you all for the good support. And thanks for everything.
Thank you, sir. Thank you.
அடிரவிண்ணிருளில் நிலவின்னொளியில் நின்றாயே நீயே அந்த கணம் முதலே கனவதிலே வாழ்ந்தேனே நானே. எல்லாருக்கும் வணக்கம். என் பேர் ரோஹித். எனக்கு ஒரு 10 வருஷமாக டைப் 1 டயபெட்டிக் இருக்குது. 10 வருஷமாக நான் இன்சுலின் போட்டுட்ருக்கேன். இங்கே காவேரி ஹாஸ்பிட்டலில் டாக்டர் கௌரி மேம்கிட்ட தான் கன்சல்ட் பண்ணிகிட்ருக்கேன். இப்போ கூட நான் நீட் கிளியர் பண்ணிட்டு ஃபஸ்ட் இயர் MBBS முடிக்க போகிறேன். ஸோ இன்சுலின் எடுக்கிறவங்க பெருசாக அதை கண்டுக்க வேணாம். அது மட்டும் இல்லாமல் நான் பேஷனாக சிங்கிங் வச்சுருக்கேன். யூடியூப் சேனல் ஆரம்பிச்சிருக்கேன். நிறையா சாங்ஸ் பண்ணியிருக்கேன். அதுலேருந்து உங்களுக்காக ஒரு சாங். அடிரவிண்ணிருளில் நிலவின் ஒளியில் நின்றாயே நீயே அந்த கணம் முதலே கனவதிலே வாழ்ந்தேனே நானே. ஓ மேகங்கள் கூடிய மேனியானதோ வெண்மேகம் உனக்கே உன்னை கண்டதும் எனக்கு காதலும் வந்தது காமேக மழை. ஓளிரும் நிலவும் குளிரும் இரவும் பெண்ணாக மாற என் மனதினோரும் காதல் நீர் கொண்டேனே நானே. சாரல் தூரும் மழையா என்னை சாய்த்து போகும் சிலையா மனதில் ஏதோ மாற்றம் செய்யும் மாய புதிரும் இவளா. இரவின் இருளில் நிலவின் ஒளியில் நின்றாயே நீயே அந்த கணம் முதலே கனவதிலே வாழ்ந்தேனே நானே.
கனவுகளை நனவாக்கும் முன்மாதிரி சிகிச்சை.
This is a wonderful song was sung by our club member, Dr. Rohit. And there are a lot of kids that are doing a real good performance. There is a swimmer is there in our team. There are good talented person with type 1 diabetes we have. And all credit goes to Dr. Kauvery and her tireless effort in bringing in Sigaram. Good. Dr. Kauvery, you can finish up.
Thank you, sir. It is really very satisfying webinar, I should say, with the highest attendance till the end of the webinar. I thank all the speakers who have spent their valuable time with us and hope to join you all in another webinar like this. Thank you, sirs. Thank you, madam. And we'll finish up this webinar with this one. Thank you, madam. Thank you.
Thank you.
Thank you.